Hello, sorry for the interruption. I think there is a small disconnection. Are you able to hear me so that we can continue from where we left? Yes, okay. So we are going to start with where we left. So that is what I was telling, that if the BP is suddenly increasing from normal value to probably a very high value in a small period of time. So this kind of sudden changes is where is going to be more important, because the body adapts to long-term problems, but newer problems, it's very difficult to adapt. So this side of conditions only you will usually encounter a press. The brain will not tolerate this kind of rapid changes only. Sudden changes is what is a problem, especially as far as the press is concerned and papilledema is concerned. The chronic changes generally don't produce this kind of problems. Then we have the cardiac issues also. So there are some cardiac problems that can be associated with hypertensive emergency. And more importantly, we need to know about the acute coronary syndrome. So ACS happening in the setting of hypertension is a very important hypertensive emergency. Heart failure can happen with hypertensive crisis as a part of hypertensive emergency. Hypertensive heart failures are extremely common, especially this ADHF, acute decompensated heart failure. Then you can develop aortic dissection. It's also hypertensive emergency, which we discussed in the previous class itself. Then we have renal issues, where the patient can develop with AKI, and even there is another thing called a scleroderma renal crisis that also presents as a hypertensive emergency only. And of course, we have some conditions that produces MAHA, that is microangiopathic hemolytic anemia, especially in the setting of a scleroderma renal crisis. And hypertensive crisis itself can precipitate a development of microangiopathic hemolytic anemia. SRC means scleroderma renal crisis. We'll be discussing that in rheumatology, where you have something called a diffuse scleroderma. In diffuse scleroderma, this SRC is quite common. So we had microangiopathic hemolytic anemia. Then apart from that, we can have preeclampsia or eclampsia. Preeclampsia, eclampsia. So I think I have covered everything. Okay. So neurological, cardiac, renal, MHA, hematologic, microangiopathic hemolytic anemia, preeclampsia or eclampsia. All these are considered to be target organ damage. And these are all considered as hypertensive emergencies if they happen with a BP of more than 180, 120. And how to treat, and what are the best drugs to treat each and everything. So that's really important. The target blood pressures are also very important, and target blood pressures in each and every scenario is also very, very important. As an overall rule, in any hypertensive emergency, this is a overall rule. The BP decrease, the blood pressure fall should be approximately by 25% in the first hour. The BP should decrease by 25% in 1 hour. This is the overall rule. And by around 2 to 6 hours, the next 2 to 6 hours, the BP target is somewhere approximately around 160/100. 160/100. So this is the BP target in the next 2 to 6 hours. Then in the next 1 to 2 days, which means in 24 to 48 hours, the BP should come to the normal range. So this is the usual target. Remember, the most important thing that you really see here in this kind of situation is the fact that you should not reduce the BP much faster. In the first hour, fine, you can reduce up to 25% in the first hour, but the normalization of the BP should be done by around 24 to 48 hours only, because many of the organs would have adapted to that high BP, and suddenly if you lower the BP, that will produce a sort of a relative hypotension to that particular organ, and they can result in more end organ damage than lesser end organ damage. So that's why BP reduction should always be gradual, not like you should reduce the BP faster. And next thing, you have aortic dissection. Why I'm telling aortic dissection as a separate entity is because aortic dissection has specific guidelines, and at the same time, this is the only condition where you have to reduce the target systolic blood pressure to less than 120 as soon as possible. So in all the other conditions, you will reduce the BP very slowly only. But as far as the aortic dissection is concerned, you should reduce the BP very faster to less than 120, and the target SBP should be less than 120. There are some other conditions where you have to reduce the BP much faster. Like for example, you have a pheochromocytoma crisis. There you have to reduce the BP faster, and pregnancy-related hypertensive complications like eclampsia and preeclampsia, where you have to reduce the BP much faster as well. So in those settings, the target systolic blood pressure will be less than 160 millimeters of mercury. Sorry, 140 millimeters of mercury as soon as possible. Which means these are exceptions to the rule. So need not wait for 24 to 48 hours in this scenario. So where you can reduce the BPs much faster to less than 120 in artery dissection and to less than 140 in other conditions like pheochromocytoma, preeclampsia and eclampsia. Then there are special guidelines for ischemic stroke as well. Very commonly we encounter hypertension in the setting of ischemic stroke. How fast to reduce the BP? This again was a matter of debate. Now the guidelines are very clear. So the problem is, remember, BP more than 185/110 is actually a contraindication to thrombolysis. In stroke also we do thrombolysis within 4.5 hours, and it's supposed to be a contraindication to thrombolysis. But remember, this is only a relative contraindication. This is not an absolute contraindication. Why? Because you can reduce the BP faster. I mean, in the sense like there are effective drugs that can reduce the BP so that it should not be an issue. That's why it's a relative contraindication. Suppose if the patient is in window period, which means the patient is having presented to you within 4.5 hours, plus there is no contraindication to thrombolysis. So in this kind of scenario, I mean, what I mean by no contraindication is there is no absolute contraindication for thrombolysis. In this setting, the only thing that is standing between you and the thrombolysis is the elevated BP. In this setting, try to reduce the blood pressure as soon as possible, which means ASAP, as soon as possible, and proceed with thrombolysis. That's the idea. You can proceed with thrombolysis. Suppose if the patient is outside the window period, which means beyond 4.5 hours or beyond 6 hours, where you really can't thrombolyze these individuals outside the window period, or if the patient is having some absolute contraindication to thrombolysis, not a relative contraindication, patient is having some absolute contraindication to thrombolysis, in this setting, once again, will be very clear that the patient cannot be thrombolyzed in this setting. So the patient cannot be thrombolyzed and the BP is more than 185/110. Now there is no urgency at all. You need not reduce the BP rapidly. Now we have to reduce BP only if BP is more than 220/110, maybe 120, 220/120 millimeters of mercury, which means you can wait even if the BP is 200/100 millimeters of mercury if you are not planning to thrombolyze the individual. Here the BP target will be, so what will be the target BP here? Target BP will be anything less than 180/110, that's all. But better if BP is less than 180/105, just 5 millimeter less than the target is much better. But it's okay to thrombolyze. Even if the BP is just 180/105, it's fine. You can proceed with the thrombolysis. You not reduce the BP extensively. My idea is to bring the patient below the non-contraindication cutoff and then proceed with the thrombolysis if the patient is in window period plus no absolute contraindication for thrombolysis. The patient is outside the window period and there is an absolute contraindication for thrombolysis, then in this setting, I'll reduce the BP only if the BP is more than 220/120. And remember, whatever the guidelines I have told will be applicable within the 72 hours of onset of stroke only. Beyond 72 hours of onset of stroke, your standard guidelines will apply. Whatever I told you, the standard guidelines, that will apply. Outside window period, we won't reduce BP gradually. Yes, that's what I'm trying to tell. You reduce BP only if more than 220/120. You don't reduce BP if it is 200/100 also, you just leave them, no problem. Because there is something called ischemic penumbra that will be lost if you reduce the BP drastically. So you have to reduce BP slowly only. That's why I told you, you should not reduce BP unless and until the BP is more than 220/120 if the patient is outside the window period. What is the target BP for outside the window period? Anything less than 220/120 is enough for me if the patient is outside the window period in the first 72 hours. After the 72 hours, your routine guidelines will apply. Within the first 72 hours, anything less than 220/120 is enough. It's okay for me, no problem. I think this should solve the doubts, and this is how you manage hypertensive emergency and with different organ damage. And previously, old guidelines told about subarachnoid hemorrhage also, where they told systolic blood pressure should be less than 160. But I don't know, newer guidelines have removed this, and they told even for subarachnoid hemorrhage, you have to follow the routine protocol only. Window period, if you want to know, is less than 4.5 hours. As of now, it is less than 4.5 hours. There are some guidelines which advocate giving thrombolysis up to 6 hours also. But usually less than 4.5 hours is what we call it as a window period as of now, a standard window period. In fact, it should be, to be effective, it should be less than 3 hours, as I told you multiple times in the past. But within 4.5 hours is also fine. That's the ideal number for exam to answer. Okay, then let us see the drugs that can be preferred. We have many drugs that can be used for hypertensive emergency. Of course, you are going to use IV drugs in the setting of hypertensive emergency. Very commonly, what we are going to use is the labetalol. Nilash is asking, what do you mean by ischemic penumbra? Then why you need neurology to be discussed? Wait for neurology. There you will be understanding what do you mean by ischemic penumbra. So labetalol. Labetalol is a very good drug you can use for many situations. So whenever examiner gives labetalol, the first thing I'm going to talk about is aortic dissection. That's the first area I can use. Apart from that, it can be used in acute coronary syndrome. It can be used in stroke. It can be used in eclampsia patients also. Even in eclampsia, we prefer labetalol as the very important drug, even in hypertensive emergency. Stroke you can use, ACS you can use, aortic dissection you can use. You can use in many situations. Labetalol is a very, very good drug basically. Then we can use calcium channel blockers like nicardipine. I mean, let us finish off the beta blockers. We have other beta blocker called esmolol. Esmolol is extremely good for aortic dissection once again. Then in acute coronary syndrome. In stroke and eclampsia, it's not studied well. That's why I told you in the beginning itself. Eclampsia, you don't use esmolol that much. So labetalol is the standard of care. And esmolol is very good in aortic dissection as well as acute coronary syndrome. Then we can use calcium channel blockers like nicardipine and clevidipine. So both nicardipine and clevidipine are better in certain scenarios. They are also very good drugs. These are IV calcium channel blockers. So where I can use in patients with stroke, but aortic dissection, these drugs are not really recommended. I can use in stroke to a great extent. Then I can use in acute kidney injury. Then I can use in pheochromocytoma. So in all these situations, nicardipine and clevidipine appear to be very effective. On the other hand, nicardipine can be additionally used in eclampsia also if you are devoid of a drug, like a nifedipine. It's like an IV nifedipine. So you can use this drug in eclampsia, where clevidipine can be used additionally in the setting of a pulmonary edema also. Hypertensive pulmonary edemas, you can use clevidipine also. Because there is some problems in using, especially in those trials. So that's why I told you that additional point. And apart from that, you have drugs like nitroprusside, you have drugs like nitroglycerin. So where are the situations where you can use these drugs? NTG. As far as nitroglycerin is concerned, you will be able to answer very easily. The first choice area where I'll be using is acute coronary syndrome, where it's going to produce pain relief, vasodilation, more perfusion, a lot of advantages. Then pulmonary edema I can use, hypertensive pulmonary edemas, where it's going to reduce the venous return. Preload will be reduced. So it's a very good drug there also in hypertensive pulmonary edemas. And we have nitroprusside. And of course, excessive use of nitroprusside beyond a particular level has a risk of developing cyanide toxicity also. That point has to be noted in exams. But nitroprusside is a very good drug only in one setting, that is pulmonary edema. Apart from that, we don't use this drug. Remember, don't use NTG and nitroprusside for cranial emergencies, especially stroke, papilledema and all. It's better to avoid NTG and nitroprusside because they can be adverse in this kind of settings. And there are other IV drugs, like for example, phentolamine. Remember, phenoxybenzamine is only a pharmacological gold standard, but when the patient comes with pheocrisis, we generally start with phentolamine, and probably we'll be starting with other drugs like nicardipine and clevidipine only. So phenoxybenzamine is only a pharmacological drug of choice. Apart from that, there is no role. Phenoxybenzamine will be using only if the patient is prepared for surgery and not in pheochromocytoma crisis. But I don't know why pharmacology books will give for pheocrisis you are using phenoxybenzamine. Honestly speaking, it is not available in emergency scenarios. Only phentolamine itself is difficult, that can be got, and more easily you can get this nicardipine and clevidipine, which is very well available in the pharmacy. So even in pheo crisis, when the patient is coming with an extremely high BP, in our hospital, we generally tend to prefer nicardipine and clevidipine only. But pharmacology books generally give phenoxybenzamine as the preferred drug, very difficult to get in the first place. And oral drug during a hypertensive crisis when the BP is 200, 100, I mean, that doesn't make any sense in the practical scenario. So phentolamine, of course, it's an alpha blocker, so I can use in pheo crisis. So that time I can use, no problem. Then you have many other drugs which you can use, like phenoldopam is there, enapatrilat is there, enalaprilat. So not enapatrilat. I confused with omapatrilat. So there is a drug called omapatrilat. You know what is that? Where it is used? Just to, I mean, it's not available in India right now, but can you tell where omapatrilat is used or where omapatrilat is important? Omapatrilat is not an obesity drug, of course. We discussed something called an ARNI, isn't it? In the last section. If you remember, in heart failure, I've discussed a lot about this angiotensin receptor neprilysin inhibitor, ARNI. Yes, it's a neprilysin inhibitor. And I mean, we use usually sacubitril and valsartan combination, but omapatrilat is like a dual drug in a single molecule. It can have neprilysin inhibiting function also. It has a angiotensin receptor blocker functioning also. It's a dual action drug, omapatrilat. So I confuse with that. There is something called enalaprilat. It's like an IV enalapril. It's like an IV enalapril. Yes, omapatrilat, mecarbil, whatever. I call it as omapatrilat, that's all. So enalaprilat is there. Enalaprilat is also a drug that is preferred in use, that sometimes can be used in a hypertensive emergency, but the efficacy is not that much proven in trials. At the same time, it is not a very good drug as well. So that's why we don't use enalaprilat right now, even though it is one of the drugs that is prescribed in the textbooks. And apart from that, we have another drug called phenoldopam, which is a pure dopamine agonist. So thereby causes vasodilation. Remember, dopamine causes vasoconstriction because of the alpha properties of dopamine. If you purely act on dopamine receptors only, it will produce only vasodilation and not vasoconstriction. We know that. So phenoldopam is a drug that doesn't work on any sympathetic receptors, and it works only on the dopamine receptors, thereby causing vasodilation, fall in the blood pressure. Usually phenoldopam is a drug that can be preferred in AK settings, but again, the validity of this statement in the textbooks is not practically tested, and I've never used this phenoldopam drug in my practice. I don't even know what is the dose of this drug in the first place. Okay, so these are the 6 drugs I wanted to tell, which can be used very commonly, and hydralazine is also there, which can be used in eclampsia. We know that IV hydralazine is available. If labetalol is not adequately controlling the blood pressure, then I can use IV hydralazine. But in general, in our hospital, we go for nicardipine only most of the times. Okay. With this, I think we have completed the hypertension, and whatever the important topics on hypertension is there, and I think we have completed it. Any doubts on this? Do you understand? If you say yes, I can move on to the next topic. Yes. I think this must be more than enough. Hypertension is a very important topic for your exams. Most of the ordinary diseases and common diseases will be a little boring, but it's good. It's important to know because these are very common diseases. Where is resistant hypertension? Somebody asked me to show the resistant hypertension part. So this is the resistant hypertension part, which you can make a note of. Your BP rises, otherwise normal patient is okay to use like that. No, any drug, it's better to use regularly. Irregular means itself you are going to have ups and downs, this kind of peaks and troughs. That's not correct. So that's not the right way of measuring, maintaining something. The right way of maintaining something is in a flat line. That's the way to maintain. It's not ups and downs. So that's not good. Duration of treatment is lifelong, or we stop. The point in complaints of hypertension. So it depends whether you're dealing with an essential hypertension or a secondary hypertension. Secondary hypertension, we have a clear idea. So once the underlying problem is done, you're not going to continue with the antihypertensive therapy. But for essential hypertension, it's always a problem. Like you don't know when to stop it. In general, we start the treatment saying that it's for long term and essentially lifelong, but we don't have any standard consensus about stopping the therapy as far as essential hypertension is concerned. Even though there are some guidelines which tell once the BP is consistently low beyond consistently normal, after 1 to 2 years, you can consider downgrading the drugs and ultimately stop and maintain the patient only with lifestyle modification. But we really don't have any proper and regular guideline for that. Drug below alpha blocker is hydralazine. I think I wrote hydrolazide strong. It's hydralazine. Diuretics are contraindicated in pregnancy. It's not like diuretics are contraindicated in pregnancy. It's better to avoid diuretics in pregnancy because of other associated complications like hemoconcentration. DVT, pulmonary embolism risk is very high if the patient is having hemoconcentration. That's why we better not to give diuretics because of other reasons. Review after depends. Again, there is a separate guideline on when to review and when to not review depending on the ACHA classification of hypertension, which I've told you. Pseudo resistance usually happens due to improper cuff sizes. Patient smokes just before coming to the OPD. Like this is what we refer to as pseudo resistance. So you have to rule out that, especially the cuff size is the most important in that setting. Okay, fine. I think we have come to a conclusion. So that's it. Isolated diastolic hypertension can happen in many situations. So that doesn't make any sense. It can happen, whenever in exam, if they give diastolic hypertension, then in this situation, you generally think about hyperaldosteronism. So this is what in exams, diastolic hypertension, especially they will give without edema. I'm writing minus edema. If they give diastolic hypertension without edema, always think about hyperaldosteronism. But isolated diastolic hypertension has the same outcome as that of the overall hypertension, essential hypertension. So if you could not find out any secondary cause, you treat like the same thing only. Or you can get this kind of diastolic hypertension in hypothyroidism also. But this is only theoretical. But practically, even diastolic hypertension has the same impact as that of elevation of both systolic as well as diastolic hypertension. Drug of choice in young hypertension patient. This is the same thing. This is looking like a CME basically, because hypertension being such a common disease. Why I know why you people are asking doubts, because you would have encountered your relatives or your parents or someone who's suffering from hypertension. That's why there are so many doubts that's popping out right now. But the idea is very simple. You have to start practicing. Once you start practicing and reading the guidelines, this will be much simpler. And whatever doubts are there, I've already addressed about that. So there's nothing to discuss more about that. I think I got it right. Okay. Then next cardiac problem we are going to discuss is on the infective endocarditis, which is also a very important thing for your exams. Even though the number of questions on IE that has been asked in the last 2 years is reduced a little, but still it becomes really important. That's what we're going to discuss next, infective endocarditis. Actually, the ideal definition of infective endocarditis is having a infection in the endothelium of the heart. You have heart as endothelium, isn't it? Your endothelium, or I can write it's an endocardium. So this lining of the heart will become infectious. So this is what we refer to as infective endocarditis. It's not the infection of the myocardium, or it's not the infection of the pericardium. So that has a different name. So infection of the endothelium or endocardium of the heart is what we refer to as infective endocarditis. So which means it's not limited to the valves. So that's the first question that you need to know. It's one of the old AIIMS question, 2013-14 they asked. So infective endocarditis means it's an infection that is limited to the valves. That's a very, very wrong statement. It can extend into any part of the endocardium or endothelial lining within the heart. It's not an infection that is limited only to the valves. Because the moment you think about infective endocarditis, you think about valvular disease. That's the next thing. So that should be avoided in the first place. And it can extend to many different areas. So definition wise, that's the definition. And you can, usually infective endocarditis, you will get in structurally abnormal valves. So that is the idea where you get infective endocarditis. So you can divide basically into two areas, infective endocarditis in patients who are having structurally abnormal valves and patients who can develop infected endocarditis with a structurally normal valve also, but very rare, but you can still develop in patients who are having structurally normal valve. Structurally abnormal valve, there are some patients who are having high risk of developing infected endocarditis in this scenario. For example, patients who are had a prior infected endocarditis are at a very high risk, because once you develop infected endocarditis, the valve will be damaged, of course, and after that, throughout the life, they are at a higher risk of developing infected endocarditis. Then prosthetic valve, of course, it's a foreign material, and it has no protection from vasculature, and it's very difficult for the drugs to reach there also. The prosthetic valve is definitely a risk. And especially when you have this kind of LVAD, ventricular assist devices, left ventricular assist device can increase the risk, because it's again a foreign material inside. Patients who are having rheumatic heart disease are at a high risk of developing infected endocarditis, especially with mitral regurgitation, especially MR. And probably even I can talk about AR also. They have a higher risk. Then patients who are having aortic valve disease, like bicuspid aortic valve, they are at a higher risk of developing infected endocarditis as well. Or any kind of cyanotic congenital heart disease. Cyanotic congenital heart disease have risk of developing infected endocarditis, any cyanotic congenital heart disease. And if at all you ask valvular heart disease with maximum risk, what will you answer? Valvular heart disease with maximum risk of developing infected endocarditis. What is your answer? Of course, very easy one. The answer is going to be mitral regurgitation, MR. MR is going to be going to have the highest risk. Suppose if I ask you the valvular heart disease with the least risk, then followed by this MR is followed by AR, AS and all. Next only ARAS. Then it will be followed by ARAS. Least risk. Least risk is with MVP, probably without MR. So if with MR also you will have a higher risk. So MVP commonly be associated with MR. So clearly you have to tell that MVP without MR means it's a least risk of developing infected endocarditis. In fact, zero risk there. There is no risk really. Then congenital heart disease with highest risk of developing infected endocarditis. They ask you, these are very common questions in exam. Maximum risk of developing infected endocarditis is VSD. Of course, more than VSD, I'll talk about the cyanotic congenital heart disease, which are having even more higher risk. But since VSD is extremely common, we tell that first in the exams. And which having least risk, of course, it is ASD. Atrial septal defect is going to have the least risk. So remember, all these risks are basically based on one thing, that is a gradient. The gradient between two areas. So that's the reason for having the risk. Whenever the gradient between two areas is very high, you will have a high risk. For example, in VSD, left ventricle to right ventricle gradient is very high. Left ventricular systolic pressure is around 120, 130. Right ventricular systolic pressure is only 20, 30. So high gradient is very high. So the damage will be very high, because the movement of blood will happen more forcibly if the gradient is high, and that more forcible blood flow will result in more damage to the areas that they are through which they are moving. So that is the reason why you develop more infected endocarditis there. And at the same time, in MR, if you take, the gradient is very high. MR happens during systole. During systole, the atrial pressures are only 5, 8, somewhere around, and the ventricular pressures are 120, 130. So the gradient you can see is very high. But why in ASD it's very low? Because the gradient between left atrium and right atrium is very, very low, almost equal. So the risk of developing infected endocarditis there is extremely low. And similarly, in other conditions, once again, like a mitral stenosis. Mitral stenosis is actually having a very low risk of getting a infected endocarditis. Why in a pure MS you don't really get that much IE? Because in MS, the movement of blood happens during diastole, which means the gradient is actually happening during diastole. And the gradient is actually quite less. The atrial pressure during diastole is very, very low, and the ventricular pressure during diastole is also very, very low. So you don't really get that much of gradient there. So that's why movement of blood is not happening that forcibly in mitral stenosis. So that is why you tend to have a lesser incidence of infected endocarditis in MS. So it's all about the gradient. Gradient is the key there to understand why you are having more risk of infected endocarditis in certain scenarios. So you have a normal valve. When you have a structurally normal valve, still you develop infected endocarditis. This will be usually due to conditions that produce bacteremia. Bacteremia in the sense, conditions that produce, sepsis kind of a scenario. So those are the conditions that are going to result in infected endocarditis. The first topmost scenario what I encounter in my practice is whenever you have a CLABSI, that is central venous catheter related bloodstream infection. CLABSI is a topmost cause in my hospital to get infected endocarditis. Many patients on catheters, we are going to get infected endocarditis. Forceful inoculation of bacteria into endothelium, then why gradient is important. Yes, of course, like the damage is more, the endothelial damage will be more. So usually infected endocarditis will not start with straight away infected endocardium. I mean infected endocarditis. You're going to result in more of a subendothelial infection first. Then only it will become a vegetation after a long time. You're talking about forceful inoculation of bacteria. Again, the gradient is more. No, whenever the pressure is more, it's going to be more forcible inoculation only. I don't really understand what your question is. Maybe I'm telling in a wrong way, but I can't understand. Forceful inoculation can happen in forcible movement of the blood. Forcible movement of the blood will happen whenever the gradient is high. I don't think what is the problem there. Okay, so CLABSI is very important as far as I know. That is central venous catheter related infections are extremely important in this scenario. And apart from that, you have this hemodialysis catheters. Again, it's like a CLABSI only. Patients on HD are at high risk of developing infected endocarditis. And apart from that, patients who are having poor dentition are at risk of bacteremia, especially who are underwent recent extensive dental procedures are at risk. Definitely if you have any prosthetic material in the heart. Apart from the valves, like ICD, implantable cardiac defibrillator wires, pacemaker wires, they can go for infection. And certain grafts, especially when you're closing the VSD, occluding the ASD. So those kind of grafts, if there is inside the heart, then also you're at a high risk of developing infected endocarditis. And apart from that, diabetes mellitus itself is a stronger risk factor for developing infected endocarditis. So which means infected endocarditis can happen with patients who are having abnormal valves, or can happen in patients with normal valves also. And of course, I didn't tell you about the IV drug abuses. Okay, IV drug uses because of the improper and insanitary drug injection practices. You can result in development of infected endocarditis. As far as the organisms are concerned, there are so many organisms are there that can produce infected endocarditis. But of course, I know the PG aspirant will be more concerned about the most common organisms only. I know that. But even though that is not important for exams, but still they will not get a peaceful sleep unless and until they don't know what is the most common organism that happens in infected endocarditis. And in a way, as far as infected endocarditis, it is important because you need to give an empirical therapy. So that's why that most common thing is also in a way important, not anyways important, because whenever you construct an empirical regimen, you make sure that you cover all the organisms, not only the most common organisms. That is the key there. So if I am giving an empirical regimen, so that regimen should be able to cover almost all the organisms which I really encounter in the infected endocarditis setting. So that is the idea of giving empirical regimen, and students misinterpret that as most common organism that should be covered more. It's not like that. It should cover all the organisms, even if it is less common, because we don't know what is the organism. That's why you are giving empirical therapy, which means it includes all the organisms. So as far as the organisms are concerned, you can split basically into native valve endocarditis and prosthetic valve endocarditis. Two things. One is NV and second is PV, that is prosthetic valve endocarditis. The NV means native valve endocarditis. As far as the native valve endocarditis is concerned, basically I can split into two. One is called subacute native valve endocarditis and an acute native valve endocarditis. Subacute, we know very well it is going to be viridans only for sure. Nothing else apart from viridans. Viridans is the most common cause. Almost 30 to 40% of the subacute endocarditis. I mean, in fact, 70% of subacute endocarditis and 30 to 40% of overall native valve endocarditis will be Streptococcus viridans only. And as far as the acute infected endocarditis is concerned, I'll be more often going towards a Staphylococcus aureus. And once again, it depends on the situation. For example, if you take the overall incidence, non-IVDA, if you take non-IVDA patients, non-IV drug abusers, non-IVDU patients, Streptococcus viridans becomes the overall most common. If you take about IV drug abusers, IVDU patients, acute is, Staph aureus is going to be the predominant organism. Staph aureus is going to be the overall most common organism if you think about an IV drug user. Suppose in exam, if you don't have an history of IV drug user, if they or if they tell you give a history of a subacute endocarditis, then you can go for Viridans without any choice. So if they have given more acute progression IV drug uses, then Staph aureus is going to be the most common overall. It's quite simple, and that's all. Overall speaking, second most common organism after like the Streptococcus viridans is going to be the Staph aureus only. So these are two organisms that usually are going to be encountered in infected endocarditis setting. Then as far as the prosthetic valve endocarditis is concerned, you can split into two things. One is called early prosthetic valve endocarditis, that happens within 2 months, and late prosthetic valve endocarditis, which can happen after 2 to 12 months. So early prosthetic valve endocarditis, of course, you are going to get this coagulose negative staphylococcus. That's going to be more common compared to other entities. So I'm going to use staph. Staph is the usual most common. As far as the early prosthetic valve endocarditis is concerned, where I can think about cons and Staph aureus as the most important organism. So in the late period, after 2 to 12 months, your etiology will be very, very similar to that of native valve endocarditis. So which means like native valve endocarditis, you can assume the same. So that's not going to be very different. So in exam, what to answer? That's the question, because you don't get this kind of exams. Person who's going to ask this kind of questions are regarded as very dumb, basically. But anyways, nevertheless, whatever may be the case, you should answer in exam. So if you want to know the most common, I will vote for Viridans, followed by Staph aureus, if it's a native valve endocarditis. As far as prosthetic valve endocarditis is concerned, I will go for cons in the early period, and in the late period, once again, I'll go for Viridans in the late period. So if at all you want to really answer in the exams, apart from that, I don't want to confuse this any further. And remember, different data will tell different results. For example, if you take the CDC recommendation, that will tell a different value. If you take probably Braunwald textbook, it will give a different number. And if you take Harrison, it will give a different number. So why they're giving different number? They're not giving different number. They're only giving results based on their particular research. And it's our stupidity to believe a particular book telling that this is the gold standard. No, we should actually find out in your hospital, or you should be able to find out in your locality what is the most common organism, rather than trying to find out from someone else's study and telling that this is the most common organism. That can give you a structure. Other trials may give you an idea, but you should always try to do research in your own setting and find out what is the common organism. For example, in my hospital, ID is very strong. In the sense like microbiology is also very strong, because the consultants are good. Microbiology consultants are also very good. And basically speaking, they used to give a data to us. Every month they used to give a data in a meeting, in a common meeting, where they tell what organisms we have encountered in the last maybe month. And overall 3 months, they will give a trend. So what is the trend of organisms that is happening in the hospital in the last 3 months? So they will give it in the form of a graph. In every HIC meeting, we call Hospital Infection Committee. So in every HIC meeting, they used to give a trend. For example, there will be a mandatory Staph aureus trend will be there, because this is very important. So whenever we see a rise in the Staph aureus trend, like at least more than 5% from the previous month, we always think that this must be due to poor hand hygiene practices and improper sanitary reasons. So that is why then we'll take the hand washing protocol, whether it is implemented properly or not. Then we try to control all those things. Don't believe next month, once the hand washing and the proper hygiene has been enforced again with proper CCTV cameras and all these things, this will come back to normal again. So it's not like thinking about the most common and you're going to give that as the standard of care. It's all about understanding what's happening underneath and treating that as a primary reason to clear off the infection in your particular hospital. So hospital-acquired infections are going to be the future, because so many resistant organisms are emerging from the hospital only. So be very careful about that. So I believe that these kind of most commons literally doesn't make any sense, to be honest. It's all about your local policies and what your hospital is encountering and what you are encountering. And that's what is going to make a lot of difference in treating the patients, because we are learning medicine to treat. We are not learning medicine to learn medicine. there are two differences. Now the problem with the students is they are learning medicine because they want to learn. They don't want to treat. Knowledge is right now everywhere. Students know everything. But at the same time, I will tell students know nothing, because when they come to my hospital for internship or residentship, I really feel when you ask an MCQ, they answer just like this in 2 minutes. When you ask the person to, tell what is the theory behind it, they will immediately tell from the pathophysiology to the treatment, but they do not have confidence to write a drug in the case sheet. They will always keep calling me, sir, can I give this drug? Can I give that drug? Even after 2 years, 3 years of residentship, they are feeling the same problem, because they don't really get that confidence, because they are right now living in a virtual world only. They don't want to come to the reality, and they start that, that fire of treating and getting that kind of satisfaction. I don't know how it is going to go in the future. And I believe this COVID has made the situation even more worse, where the students are actually now totally in the virtual world. They are not even coming to the real world in the first place. Okay. So what are the clinical features of infected endocarditis? We have told about the common organisms. Any question? In the common organisms, no questions, right? So let us leave that. Anyway, I told you the base, whatever you needed is there in this particular table. So we don't really need that right now. Candida, yes, they can cause. We'll discuss about that. What you will do in fungal endocarditis. So what are the clinical features? So clinical features, the most important feature is going to be the fever. And of course, a student really asks about the most common. They ask about the most common. Then fever is going to be the most common, present in almost more than 90% of the individuals. They can come without fever also, 5 to 10%, but more than 90% will have fever. And why fever? That is because of persistent bacteremia. Persistent bacteremia. That's the reason why they have fever. And more importantly, what you should know with regards to this infected endocarditis is the persistent bacteremia. So why this word persistent bacteremia is important in infected endocarditis? Because heart is an organ where all the blood meets at a common place, which means wherever the blood goes, doesn't matter. The final destination is the heart. From the heart only, it should be distributed to the other areas. If the heart is infected, and especially if the endothelial lining of the heart is infected, it's 100% sure that every single ml of blood will be drenched in that infective organism. So that is the idea. Every single ml of blood, I mean, I'm exaggerating, but still, that's really important to understand. Every single ml of blood will contain the infectious organism. That is the basic rule. If you take a urinary tract infection, or if you take probably some other colitis or some other infection, only a part of the circulating blood is moving to that particular organ. And only that part of blood will maybe probably containing the infectious organism. Other areas may not really contain. That's why the yield of blood culture in different septic conditions is completely different. Overall yield of any septic condition having a positive blood culture is approximately 30 to 40%, despite having severe bacteremia. But infected endocarditis only, the yield of blood culture virtually becomes 100%, at least 80 to 100. So why this is the reason? Because heart is the meeting point for everything. Almost all the blood that is coming from different parts of the body. So every ml should contain organism as a rule. And that is why that word persistent bacteremia is the key. So it's not just bacteremia, it is persistent bacteremia. That is the actual basis of having a Duke's criteria, where it is persistently positive blood cultures. And that's why you tell infected endocarditis consistently with that particular point, persistently positive blood cultures, persistently positive blood cultures. It's not about having a single positive blood culture. If you're having infected endocarditis, there should be a persistent bacteremia. If you have a persistent bacteremia, you should have a persistently positive blood culture. That's the key there. And apart from the fever, you can get heart failure because of valvular regurgitation. We'll think about that. Then you can get sort of immune reactions. Some immune phenomena is there. Can you tell what are the immune phenomena? There are 4 immune phenomena are there. I'll come back to the other things in some time. So what are the immune phenomena? Yes, oscillus nodes, but these are rare to see. Apart from that, Janeway is not immune phenomenon. Janeway is a vascular phenomenon. Yes, rod spots. Rod spots are correct. Then, yes, RF positivity, rheumatoid factor positivity, and glomerulonephritis. And remember, this is given in the criteria, Duke's criteria, but you might have arthritis also. That is because the serum sickness that these patients develop, that's an immune phenomena there. And even increased ESR, CRP are also considered to be a part of the immune phenomenon only. But anyway, even though these things are not given in the criteria, what I have marked in green here, these are the things that are given in the Duke's criteria. So that's why I told you that first. Then you have certain vascular phenomenon. So what are the vascular phenomenon? That is due to septic emboli. So what are the vascular phenomena that you get as far as Duke's criteria is concerned? What are the vascular phenomena, man? Yes, Genevieve lesions, of course, previously you told. Okay, then splinter hemorrhages, all right. Cool. Then what else? Genevieve lesions, splinter hemorrhages. Correct. Mycotic aneurysm. Mycotic aneurysm, even though the name is a misnomer, but we know mycotic aneurysm is basically a infective aneurysm. The most common cause of developing mycotic aneurysm is Staph aureus only. Staph aureus is the usual organism that produces this kind of infective CNS aneurysms, mycotic aneurysms in the CNS vasculature. Yes, you can get ICH. That's again a septic phenomenon. Then apart from that, you can get stroke. And this is not in the guidelines, but still, that's not in the criteria. You can get stroke. You can get pulmonary embolism also. Pulmonary embolism can be seen if it's a right-sided endocarditis. If it's a right-sided infected endocarditis affecting the tricuspid valve predominantly, then you can get pulmonary embolism. Stroke is common if it's a left-sided infected endocarditis, very commonly. I didn't tell you about 2-3 important organisms here. 2-3 important organisms we have not discussed. Even though we have discussed the organisms, the one organism I want to discuss is on IV drug abuse, are very commonly asked. Of course, it is Staph aureus. Then the second one is about the GIT issues. If you have some GIT problems like colon cancer or probably ulcerative colitis or colonic polyps. So what is the organism that you will encounter usually? You will encounter an organism called the Streptococcus bovis. I mean, right now the Streptococcus bovis has been renamed to something called Streptococcus galolyticus, but this is a common organism that are going to encounter, Streptococcus bovis. Whenever you encounter GIT issue like colon cancer or ulcerative colitis or a colonic polyp, we are going to get an organism commonly called as Streptococcus bovis or Streptococcus galolyticus. Clear? Very important. Then yes, we have vascular phenomenon. So we have got the vascular phenomenon. Apart from that, you have many other features of infected endocarditis. Splenomegaly is a very important feature. And sometimes you can get something called a splenic infarct. Splenic infarcts also. Whenever I see a patient who's having a fever and a splenic infarct, the next thing I'll do is screen for infected endocarditis. That's what I will do. Such a common entity, splenic infarct. Even small infarcts also should raise a lot of suspicion. When you say a hypodense lesion in the spleen in ultrasound or CT, it must be a splenic infarct in a patient who's having a fever. Even though technically speaking, malaria with a huge splenomegaly can produce splenic infarct, but that is a rare phenomenon. When you have a mild to moderate splenomegaly with a splenic infarct, generally that goes towards a infected endocarditis in a patient who's coming with a pyrexia of unknown origin. Very common. And at the same time, they can produce valvular regurgitation. That's really, really important. Remember, infected endocarditis commonly produces valvular insufficiency rather than producing valvular stenosis. So remember, stenotic lesions may be a cause of developing infected endocarditis, but stenotic lesions will not arise due to infected endocarditis. If there is an infected endocarditis, there will be usually destruction of the valve. Because of that, you will be resulting in valvular regurgitation or valvular insufficiency only. So whenever you think about, whenever you get a new MR or a new AR, this is the key in a patient with a fever. So this is going to be the key for identifying infected endocarditis in exam. So and this valvular regurgitation will be usually acute in nature most of the times. If it's acute in nature, they will develop a rapid heart failure. Remember, any chronic heart valvular regurgitation will not result in much issue. But acute valvular regurgitations will result in rapid development of heart failure. That's very important to understand, depending on the amount of heart failure that these patients are encountering. And more importantly, there is this rod spots has been a matter of question for a while, because 2 years back also they asked about rod spots. Is rod spots very specific for infected endocarditis? No, it's not specific for infected endocarditis. It can be seen in other conditions like HIV, leukemia, and many other conditions. So that's why if you take many journals, ophthalm journals, they will tell rod spots and the eye are window to other diseases. So there have been a lot of ophthalm journals which tell that leukemia as a cause of rod spots. Because infected endocarditis is going to produce rod spots, even a second year student is going to answer that. But leukemia causing rod spots is what we need. That's what the examiner expects in exam. So keep that point intact. Very, like rare, but still it's a very important one for exams. Leukemia causing rod spots. And at the same time, the difference between Osler's nodes and Jannevi lesions. Osler's nodes is basically immune phenomenon, and mostly it will be a painful lesion, and it will be usually seen in the fingers and toes. Whereas Jannevi lesions are septic phenomenon. They are basically painless, and they'll be seen in the hands and feet. Hands and feet are, I feel, different from fingers and toes. Palms and soles is what I'm talking about. So that's where you will see the Jannevi lesions, and especially the fingers and toes are the places where you see the Osler's nodes, which are supposed to be painful and due to immunological phenomenon. And as far as the glomerulonephritis is concerned, the usual form of glomerulonephritis that will happen in setting of infected endocarditis is membranoproliferative glomerulonephritis, or rarely a membranous glomerulonephritis. But if you want to choose one answer in exam, I will generally choose a MPGN, membranoproliferative glomerulonephritis. That is a type of glomerulonephritis that you're going to get with infected endocarditis. And as far as the rod spots are concerned, they are basically hemorrhagic spots. That's again very important. That is due to immune complex deposition. Because the immune complex deposition in a particular vessel, there will be a local hemorrhage surrounding this area. So you will see a retinal vessel, arteriole, with an immune complex deposition, which will be surrounded by a local hemorrhage. So this hemorrhage is very important to identify these rod spots. And usually how they will be seen is the central white, I'm drawing in black here, but it will be a central white spot surrounded by a hemorrhage. A central pale spot surrounded by a hemorrhage. That's how you describe a rod spot, basically, when you see in a fundus. If you see rod spot once in fundus, you will never miss it again. It's a very classic thing that you see in the fundus. I've even seen some 7-8 cases of infected endocarditis producing rod spots. Leukemia, 2 cases I have seen which produces rod spots. Incidentally, I found out through other routine examination, we have found out a rod spot in leukemia. That's why I told you that point is really important. I've been asked 2-3 times in exams as well. So valvular regurgitation. And apart from valvular regurgitation, they can cause perivalvular infection also. This perivalvular infection also can result in the development of CHF because they infect the other areas of endocardium. So they can result in congestive cardiac failure. And apart from that, they can result in conduction abnormalities. This is really, really, really important. That's why after diagnosing infected endocarditis, it's very important to do routine ECGs. And we do daily ECGs most of the times, even though guidelines tell 2 to 3 days once. I generally tend to do daily ECGs as far as the patient has been in the hospital. That is because to look out for this new development of conduction abnormalities. If I diagnose infected endocarditis, and if the patient is getting antibiotics, still if he's getting conduction abnormalities in the day-to-day ECG, I will think that the antibiotics are not working, and that's why the infection is spreading, causing new conduction abnormalities. At the same time, in exam, if they give fever in a patient, plus if they give conduction abnormalities, like prolonged PR and all this stuff, so usually you think about either an acute rheumatic fever, especially if the patient in question is a child, or you think about an infected endocarditis if the patient is question is a diabetic or an adult or on hemodialysis or having already a valve disease. So in these patients, I'll be diagnosing an infected endocarditis. So conduction abnormalities in a child developing a fever usually goes towards ARF in exam. That's a very common question. Or conduction abnormalities in an adult with some risk factor for developing developing fever is usually IE diagnosed in exam. So this is how the examiner gives questions in exam as well. So you have to be very clear in how the questions are being asked. And remember, there can be violation of these rules, especially in subacute infective endocarditis. Usually less virulent organisms like strep viridans will produce only subacute infected endocarditis, where the patient may not have fever at all in the first place. That's why I told you fever is not universally seen in all the cases, but even though it's the most common symptom, where in subacute endocarditis, patient may just come with fatigue and probably some kind of non-specific symptoms like arthralgia, myalgia. So you really can't pick up. So you need a high degree of suspicion there. So that's really, really difficult. Anyways, so this is going to be the feature, overall clinical feature of infective endocarditis. Then how you're going to establish a diagnosis. So for that, we need to know the Duke's criteria for infective endocarditis. Currently, we use something called a modified Duke's criteria, where you have something called a major criteria and a minor criteria. So major and a minor. So first of all, as far as the major criteria is concerned, the blood cultures are the key. Number one. So the blood culture sensitivity. Remember, we are talking about a persistently positive blood culture. That's the first one. I told you why it should be persistently positive. Persistently positive blood culture is the key. That is the basic idea of Duke's criteria. Original Duke's criteria also relied completely upon the persistently positive blood cultures. And it should be at least 2 separate cultures taken at least 24 to 48 hours apart. Or you can take 3 cultures 1 hour apart from different areas. That's also fine. Either 2 cultures taken 24 to 48 hours apart, or in a faster world, you can take 3 to 4 cultures at least 1 hour apart from the previous culture from different areas. So this is point number 1, persistently positive blood culture. That's the basis of Duke's criteria. And second thing, especially with Coxiella, you won't get the blood culture positivity. So we do serology there, especially for organisms like Coxiella burnetii. So if the Coxiella serology is more than 1:800, so that is enough to tell it's an infected endocarditis in a patient who's suffering from a fever. And apart from that, number 3 is patient is having echocardiographic evidence. In echocardiographic evidence, you need to have endocardial involvement. We're not talking about a valvular involvement, because that's the reason why initially I told you it's a endocardial disease. It's not a valvular disease. So in echo, we have to see endocardial involvement. Endocardial involvement. This evidence of endocardial involvement can be either a vegetation, which you can see in the valve or in some areas of the endocardium, or I can see an abscess that is getting developed, or I can see something called a new valvular regurgitation, as I told you multiple times in the past. And at the same time, there is something called a new valvular dehiscence, if it's a prosthetic valve. What do you mean by valvular dehiscence? Dehiscence means it's like tearing of the valve from the annulus that has been stitched already. If it is completely, coming out of the stitching that is done, that's what we refer to as a valvular dehiscence that can be identified easily in the echocardiogram. So if any one of these is there, this becomes the major criteria in the modified Duke's criteria. And in the minor criteria, number 1, we have predisposing conditions. Already I told you what are the predisposing conditions we have discussed here. So these are supposed to be the predisposing conditions. So if there are predisposing conditions, then that becomes really important, one of the important minor criteria. Then of course, fever more than 38 degrees Celsius is one of the important criteria as well. The patient is having immunological phenomenon. We know what are there. Rod spots are on the top of the list. Then we have rheumatoid factor positivity, glomerulonephritis, and Osler's nodes. Then we have vascular phenomenon like septic emboli elsewhere, which we have discussed already. Or we have blood culture positivity. Blood culture is positive, but not meeting major criteria. In the sense, like I told you, both the blood cultures, I'll come back to that, not meeting the major criteria. Not meeting the major criteria, which means how will you take blood cultures in as far as the major criteria is concerned? There should be at least 2 blood cultures positive. At least 2 cultures should be positive, taken 24 to 48 hours apart. So usually we prefer 24 hours, but 24 to 48 hours should be apart, and both the blood cultures, which means I can write 2 out of 2 here. So if you take 2 cultures, both the blood cultures should be positive. Or alternatively, you can take 4 blood cultures or 3 blood cultures. At least 3 out of 4 blood cultures you take should be positive, that has taken 1 hour apart. 1 hour apart, at least 3 out of 4 cultures should be positive. Suppose if you have taken 2 blood culture, but 2 are not positive, only 1 is positive, then that becomes a minor criteria. If you have taken 4 blood cultures, but only 1 is positive, or if you've taken 4 blood cultures, only 2 is positive, not 3 is positive, then in that setting, it will become the point number 5 for minor criteria, which means blood culture positivity that is not meeting major criteria will come under minor criteria only. So this is basically the Duke's criteria. When can you tell definitive involvement? So if you have a 2 major criteria, then it's a definitive infected endocarditis. Or if you have a 1 major plus 3 minor criteria, or all the 5 minor criteria is there. In this setting, you can call it as a definitive infected endocarditis. So these are the definitions of a definitive infected endocarditis. Then you have definitions of probable infected endocarditis also, or a possible infected endocarditis, where you have 1 major criteria only. Along with that, if you have 1 minor criteria only, or you have 3 minor criteria, but you don't have all the 5 minor criteria. So in this setting, you can call it as a possible or a probable infected endocarditis. So these are evidences of definitive infected endocarditis most of the time. And again, the sensitivity of and the specificity is quite variable. Based on the modified Duke's criteria, the sensitivity is supposed to be almost 85 to 90%, not 100%. No criteria can be 100% sensitive. At the same time, the specificity is supposed to be approximately 95 to 100%. Specificity is very good, but sensitivity is a little less. And as far as the diagnosis is concerned, of course, the cornerstone is blood cultures. You need to take adequate blood cultures. And one common thing that you miss is the more volume of blood you take, more is the ability to pick up organisms. Take more volume if you want to pick up. So in my hospital, I generally advise them to take 10, 15 ml instead of 5 ml, 4 ml. So liberally, if you take more volume, that is clearly a lot of studies are showing that you can get the organism. The sensitivity is going to be high. You can pick up organisms better. So get adequate volume. At the same time, make sure that you take at least 3 sets, even though Duke's criteria sells 2 sets. If you take 24 to 48 hours apart, but you're not going to wait till that. At least make sure you take 3 sets and take aerobic, anaerobic cultures, and you make sure that you take from different sites. Ideally, all this has to be taken 1 hour apart and try to take from different sites. It's better. If you can't take, then that's fine. If you're limited by vascular access, then it will be fine. But it's appropriate to take from different areas. That's very important. And whenever you take, send to aerobic culture, anaerobic culture, and fungal culture as well. That's very important. So especially if you suspect infected endocarditis, all these 3 are very important. At least minimum you take an aerobic and anaerobic culture for sure. That's the least minimum, because there are a lot of anaerobic organisms which can cause infected endocarditis as well. And second thing is echocardiogram, which becomes a very important cornerstone. As far as echocardiogram is concerned, this first line echocardiogram is transthoracic echo only. First we'll do TT. This is the screening kind of an echocardiogram. If you pick up the vegetations or if you pick up the abscess in TT itself, that's fine. So you can straight away diagnose infected endocarditis, not a problem, because it's low cost and it's convenient for the patient. If TT is negative and if you have a strong suspicion, then you can proceed ahead with TE. If the TE is positive, then again you can make a diagnosis of infected endocarditis. If TE is negative, then in this setting, you have to think about alternate possibility. But still, if there is suspicion, you have to redo a TE. But very commonly, if TE is also negative, then you can think about a alternate possibility. But remember, TE is the investigation that is going to have very high sensitivity in picking up infected endocarditis. TE basically, as an investigation, it fails a lot because it's going to have a very low sensitivity, not a high sensitivity at all. TE is going to have an extreme low sensitivity. So initially we do TE just because the patient can feel convenient, and at the same time you can pick up some 40-50% of infected endocarditis with TE itself, which is available on the bedside itself. That is the reason why we do TE first. If it's negative, then you can proceed ahead with the transesophageal echo if you strongly suspect infected endocarditis in the particular patient. And at the same time, ECG is also a very important investigation because you need to find out those conduction abnormalities. I told you why we do ECG routinely, in fact, in all admitted patients. Next, coming to the treatment. This is going to be the most important as far as infected endocarditis is concerned, because very commonly asked and very commonly liked by the examiners is this treatment part only. So first question you will be getting is empirical treatment. What is the choice of empirical therapy? Depends on whether it's a native valve endocarditis or prosthetic valve endocarditis. If it's a native valve endocarditis, we generally start with vancomycin to cover MRSA. Of course, Staph aureus is always in the question. Plus, very commonly, we use something called a ceftriaxone. This is the usual therapy that we'll start in a patient with a native valve endocarditis, very commonly. And if it's a prosthetic valve endocarditis, especially less than 12 months, within the first year. Remember, after 12 months, prosthetic valve endocarditis will be treated as the same as that of native valve endocarditis. So I can write prosthetic valve endocarditis more than 12 months and native valve endocarditis. Both will be treated in a very similar way. You're going to treat with vancomycin and ceftriaxone only. As far as prosthetic valve endocarditis within 12 months is concerned, so in this setting, I'll be giving a vancomycin plus ceftriaxone, plus I'll also prefer adding a gentamicin just for augmentation, because these organisms tend to be a little resistant, like Coagulous negative Staphylococcus. Plus or minus, I can give rifampicin, because rifampicin sometimes breaks the biofilms, because this is a foreign structure prosthetic valve. If it's a prosthetic valve, sometimes the organisms can produce sort of a biofilm. Because they produce biofilms to break that, sometimes rifampicin may be required. So you can add depending on the personal expertise, but the guidelines tell that these are 3 important drugs that you should add if it's a prosthetic valve endocarditis, according to ACC/HA guidelines. Then second, if you know the organism, this was the empirical treatment. Suppose now, because of course you have to de-escalate the antibiotics once you know the organism, because infected endocarditis having a negative culture is very rare. If you get in soup with a negative culture, then it's really, really troublesome. You don't know what antibiotics to give. So that is the reason why you need to know the organism. So once you know the organism, the situation becomes very simple. You know it's a staph. So now you need to know whether it's an MSSA or whether you need to know it's an MRSA. If you know clearly it's an MSSA, no need to give any vancomycin in this setting. It's better to prefer only either an ampicillin or cefazolin. In our hospital, we keep cefazolin as the standard. It's the first generation cephalosporin, extremely effective against MSSA, and it's going to be more than enough. And ampicillin, we know it's a anti-staph penicillin. We have 4 divisions of penicillin, isn't it? Natural penicillin, anti-staph penicillin. Then we have aminopenicillins. Then we have anti-pseudomonal penicillins. So ampicillin, cloxacillin, dicloxacillin are all anti-staph penicillin, which are tailor-made to act against this Staphylococcus aureus. But if it's an MSSA, this is going to be the best choices. Don't give any unnecessary drugs. That's what I use. In fact, if it's an MSSA, usage of vancomycin is supposed to be inferior, not superior, if it's an MSSA. If it's an MRSA, then no question, vancomycin is going to be the superior drug. Vancomycin, or alternatively, you can use daptomycin also, any one drug. So you can use either vancomycin, or you can use alternative drugs like daptomycin. So remember, what is the disadvantage of daptomycin? Can anyone tell? What is the problem with daptomycin? What is one issue with daptomycin where you feel that daptomycin need not be used? No, not pulmonary fibrosis. Daptomycin is ineffective if it's a pulmonary focus, ineffective in pneumonia. I think I've told you this in many of my free classes in Unacademy also. So daptomycin is supposed to be ineffective in pneumonia, basically, because daptomycin is impaired by surfactant. So you cannot use daptomycin there.
Sorry, I'm having problems with the connection. Check.
I think my Siri gets activated every time. Okay. Because I didn't daptomycin and Siri gets activated in that. Ineffective in pneumonia because it's inactivated by the surfactant. Okay. Then we know the staph, how to treat. Then you have Enterococcus. Enterococcus is a little difficult, but basically most of the Enterococcus will be sensitive to ampicillin most of the times. You can add ceftriaxone and gentamicin for boosting. Ceftriaxone and gentamicin for boosting, but most of them will be sensitive to ampicillin itself. Then you have vancomycin resistant Enterococcus. If you are encountering this kind of VRE, vancomycin resistant Enterococcus, then your choice will be either a linezolid or probably a tigecycline must be okay with that. And even you can use a daptomycin. But in our hospital, we generally go for the tigecycline related kill. That's what we do in our setting. We have a separate antibiotic protocol. But anyways, VREs, any one of these 3 drugs are efficient. Linezolid, tigecycline or daptomycin must be useful. So there is something called big six. What are the big six? These are the drugs that are usually going to cover MRSA. What are the drugs? You have vancomycin or teicoplanin. Both are under the same category only, but teicoplanin has a little bit of lower risk of nephrotoxicity. That's all. Colistin. My God, Naveen. We are talking about MRSA and you're telling colistin. My God, colistin is exclusively used only for gram-negative sepsis. You cannot use colistin for gram-positive. Big six means you have linezolid, then you have daptomycin, then you have tigecycline, then we have quinupristin, dalfopristin combination. It's available in the brand name called Sinercid, very commonly used drug by many ID practitioners. But I don't use this very commonly. But IDs use this thing very commonly. And sixth one is the 5th generation cephalosporin. Remember, no cephalosporins are active against MRSA. Only cephalosporin that is active against MRSA is 5th generation cephalosporin, that is ceftaroline. So this is actually a tailor-made drug for MRSA. That's why it's working. None of the other cephalosporins and none of the other beta-lactams work in the first place for MRSA. So in that, all the drugs can work against MRSA, no problem. With some small technical difficulties, everything can work for MRSA. If you really think about VRE, because another drug is there, vancomycin-resistant enterococcus, in that you can use linezolid, daptomycin, tigecycline, even quinupristin, dalfopristin to an extent will be effective for VRE, but only there are certain strains of VRE that quinupristin, dalfopristin will be working. So that I generally do not use this for VRE. Remember, in enterococcus itself, we have fecalis and faecium. Only selected VRE will respond to this quinupristin, dalfopristin. So that is the reason why I generally prefer any one of these three drugs, linezolid, daptomycin, or tigecycline, as a standard drug for VRE care. Quinupristin, dalfopristin is not a good drug for VRE, to be honest. Vancomycin-resistant enterococcus. He's asking about mupirocin. That's a topical drug. Can you give IV mupirocin? I don't know if there is anywhere IV mupirocin. You tell me. We are talking about a bacteremia here. We're talking about a sepsis. Where come mupirocin came here? Or I think Riju is going to open up the heart and put a mupirocin ointment in the valves and the endocardium and come back. Okay. Clear. So we have enterococcus here. No, sir, for MRSA in general. Okay. I mean, many topical ointments are there, man. Okay. I mean, I'm talking about the anyway. I just told for fun only. Topical ointment is there that can work, but we are talking about a sepsis here, bacteremia. So enterococcus is fine. So then you can get a lot of gram-negative organisms like Pseudomonas, HASSOC group of organisms. If you're encountering a GNB, I mean, GNB is a common term used in our hospital. That's gram-negative bacteria. In gram-negative bacteria, very commonly you're going to have Pseudomonas. We'll study more about Pseudomonas when you're talking about pneumonia. So you're going to add 2 drugs. So usually in the setting of Pseudomonas, you will have one primary cover. Primary cover, it must be an anti-pseudomonal penicillin like piperacillin, tazobactam. Or you can use meropenem or imipenem, or even doripenem is effective. Ertapenem is not effective. That point should be noted. Meropenem or imipenem or even doripenem, but commonly used is meropenem or imipenem. And another primary cover that you can use is aztreonam if the patient is having some penicillin allergy. Apart from that, cefepime is also okay. Otherwise referred to as ceftazidime. Ceftazidime is also okay, but currently we don't prefer ceftazidime that much. We prefer any one of these 3 drugs because some Pseudomonas in our hospital started showing ceftazidime resistance also. So one of these 3 drugs you can start. Cefepime is a 4th generation cephalosporin, or you can use a carbapenem, or you can use a piptazo. Any one of these drugs can be used for a primary cover. Plus you need to give some secondary cover, additional cover also. Cefaperazone, sulbactam, even though the culture says it can be sensitive, but most of the in vivo bugs are basically non-sensitive to cefaperazone. So cefaperazone is not really considered right now for pseudomonal cover. We use only these drugs. Technically, yes. Practically, 100% no. So for secondary cover, you can use one of the drugs like aminoglycosides, which are effective against Pseudomonas, and we can use fluoroquinolones. The aminoglycosides generally we prefer is gentamicin, and for fluoroquinolones, we can generally use probably levofloxacin, because only the third and fourth generation fluoroquinolones are effective against Pseudomonas, like levofloxacin, moxifloxacin. Other quinolones are basically not effective against Pseudomonas. Aminoglycosides, almost all the aminoglycosides are effective against Pseudomonas. So you need to add one drug from primary cover and one drug from secondary cover. That is how you construct a anti-Pseudomonal regime. And more importantly, rifampicin is not added only to break the biofilms. Rifampicin is also, because it's a protein synthesis inhibitor, rifampicin can also prevent resistance to a large extent. Because you're going to give these antibiotics for a long time, you need to sometimes add a drug that prevents resistance. And gentamicin also can prevent resistance. It's like a boosting effect. Gentamicin is based like a booster. It can also be useful in preventing resistance. So that is the reason why we add gentamicin and resistance. Gentamicin and rifampicin, not resistance. Gentamicin and rifampicin, they can prevent resistance, and rifampicin can break the biofilm to a great extent, being a strong protein synthesis inhibitor. Then you have HACCP group of organisms. Haemophilus, actinobacteria. Then you have Echinella, Kingella. Then C stands for Cardiella, like HACEK, HACCP group of organisms. So all these organisms are very well responsive to ceftriaxone. So if they give HACCP group of organisms, your answer will be ceftriaxone in that situation. Suppose if you're encountering a fungal endocarditis, fungal infected endocarditis, then probably you can think about adding a liposomal amphotericin B, or you can add these kind of echinocandins. Echinocandins will be perfect in this scenario, but liposomal amphotericin B will add only in very sick patients, very broad spectrum drug. But in our hospital, we have a standard of using echinocandins most of the times. We either use a caspofungin, or we use a micafungin, or we can use a anidulafungin also. But in our hospital, we use caspofungin very commonly. But according to the guidelines, micafungin is fairly better compared to that of the caspofungin. So micafungin is also okay. But in our hospital, we have a standard protocol for that. So you can use micafungin. Flucytosine, I don't think it's advocated for infected endocarditis prophylaxis. I'm sorry, infected endocarditis treatment. Infected endocarditis therapy is concerned. Fine. So these are the antibiotic choices. Each and every antibiotic choice is very, very important, and definitely a matter of question in exam. All these things are important. Then what are the indications for surgery? When you're going to do surgery in the setting of infected endocarditis? What are the indications for surgery? So as far as I know, the first indication is always severe or refractory heart failure. Refractory heart failure due to infected endocarditis, definite indication for surgery. You have to debride them. No need to worry about that, especially in the setting of a cardiogenic shock. Surely you have to take the patient for surgery, because you have to remove the focus. Then only they will get better. At the same time, if the patient is having usual reason for refractory heart failure will be severe valvular regurgitation. Most of the time, this will be due to severe valvular regurgitation or severe valvular dysfunction. So this is the usual reason for doing a surgery. And second indication is if the patient is having an uncontrolled infection. Evidence of uncontrolled infection usually comes in the form of persistent positive blood cultures. Even after 1 week of antibiotics, even after 1 week of antibiotic therapy and appropriate antibiotics. You're not talking about inappropriate. Even if you're giving a culture related appropriate antibiotic regime, even after 1 week, if the patient is having positive blood cultures, then in that setting, you can ask for a surgical consult. Remember, that's the reason why we repeat blood cultures every 48 hours in patients with infected endocarditis to see when the blood culture become negative. Even after 1 week of appropriate antibiotics, if the patient is having positive blood cultures, then it indicates probably antibiotic failure or uncontrolled infection. Then in that setting, you have to go for surgery as soon as possible. So if the patient is having abscess formation, then abscess is one indication to drain, especially periannular abscess. Definitely you have to drain them, and this forms one of the important indications for surgery. And very large vegetations, huge vegetations, like especially if it is more than 1 centimeter, that becomes an indication for surgery. I mean, that's a relative indication only, not an absolute indication. Usually the first two are absolute indications. Abscess is okay, relative, but in certain settings you can do. I don't want to confuse you because there are a lot of class 1, class 2A, class 2B and class 3 indications are there. Don't want to confuse. I'll tell the common indications in the first place. Then if the patient is having some sort of conduction abnormality like heart blocks, and again that indicates an extension of infection into the other areas of the endocardium. So in conduction abnormalities, you can try surgery in this setting. Or in many patients with fungal endocarditis, very difficult to treat with antibiotics, so you can consider doing a surgery. Or any other difficult to treat organisms like MDR organisms, multi-drug resistant organisms, or probably for Staph aureus, you can probably consider surgery. But remember, this is only a very relative indication. This is not an absolute indication. I mean, it depends on case-to-case basis. The patient responds to antibiotics well, then it's okay, no problem. The patient doesn't seem to respond that much. Cultures have become negative, still the patient looks sick. Fever is not settling. So only again depends on patient-to-patient basis, but you can consider surgery in these situations where you can do surgery possibly. Then what else? I think we have covered almost all these things. The most important is going to be the refractory heart failure and severe valvular dysfunction. That's going to be the most important indication. Then uncontrolled infection. And prosthetic valve endocarditis, again, it's difficult to treat. It becomes a relative indication only because prosthetic valve is a very difficult area to reach because it doesn't have any native blood supply. It's a mechanical valve. It's a metal. So how can you reach antibiotics there? Surgery means you have to debride and possibly you have to do valvular replacement also. That is what I mean by surgery. I mean, not heart replacement, Riju. We don't do transplant here. We are only debriding and replacing the valve if possible. That's all. That is the surgery we do. It's not easy to get the heart by doing a transplant. It's not heart replacement. Okay. And more importantly, it's important to think about what are the prophylactic drugs that you have to use. Prophylactic drugs. So what are the indications for prophylaxis? First of all, first question is, what are the indications? And second question that you have to ask is, when to use these drugs? During what procedures? And what drugs? These are three questions you have to ask whenever you think about an IE prophylaxis. When you think about an IE prophylaxis. So as far as the indications are concerned, the first indication is going to be, there are 6 indications basically. The first indication is the prior infected endocarditis, where I told you it's going to be the most important one. And second, because these are high risk features. Then second, if the patient is having any cyanotic congenital heart disease, that is unrepaired, definite indication. Then third, if the patient is having any congenital heart disease, whether it is repaired or unrepaired doesn't matter, but if they are having prosthetic material, they have did some procedure and there is a prosthetic material, and for the first 6 months in the beginning, definitely you have to give prophylaxis. Number 4, any congenital heart disease patient, whether it is cyanotic or acyanotic doesn't matter, if it is repaired plus at the same time there is a perivalvular leak, not perivalvular leak, there is some inefficient surgery, which means there is an ongoing leak around the prosthetic material. Ongoing leak around the prosthetic material that increase actually the risk of that gradient again will be there, so that there will be risk of development of infection in that scenario. And number 5, if the patient is having prosthetic valve. So if the patient is already having a prosthetic valve, so it's a precious valve basically. So we don't want to take a chance. So prosthetic valves are definitely a indication for giving prophylaxis. And apart from that, if you have a cardiac transplant, it's again a precious heart. Plus if this patient has valvulopathy. So they commonly develop valvulopathy because of the rejection process that is going on for a long time called as chronic rejection. And cardiac transplant with valvulopathy is an indication for giving a infected endocarditis prophylaxis. Remember, infected endocarditis prophylaxis is not currently advocated for HOCM, not advocated for MR, not advocated for MVP, mitral valve prolapse. They are not advocated. Previously it was there. Currently it was not advocated. So when you have to give the prophylaxis is the question. So these are the 6 indications, 6 disorders where you have to give prophylaxis. But when to give indications is during the time of certain procedures. Only 2 procedures are important. One is dental procedures, especially those that are involved with the gingival cavity. So when you are having any perforation or manipulation of the gingival and the oral mucosa, then those procedures. Best example is a dental extraction, implanting, periodontal implant, root canal surgeries, and cleaning procedures of the tooth. So anything that involves the gingival manipulation or oral mucosal perforation, any dental procedures, especially commonly done is the root canal procedure, that definitely needs a IE prophylaxis. Then second, I should not write respiratory procedures, invasive respiratory tract procedures. Invasive respiratory tract procedures. Best example for invasive respiratory tract procedures is bronchoscopy and biopsy. Bronch and biopsy is one of the common procedures, and again, you should give prophylaxis there. Riju is asking, how will you know when the patient will visit dentist? It's not your problem. It's a dentist problem. Dentists should be aware of this. That's why they study BDS. Okay, so they should give prophylaxis before doing that procedure. Fine. It's not your problem anymore if the patient doesn't visit you. He's asking, how will we know when the patient will visit dentist? Why it's your problem? It's the dentist problem. He's also studying, right? You think like dentists don't study at all? Or is it that your opinion? They also study the same physiology anatomy only. They study medicine also. So they should know this particular thing. They should ask history properly. And if the patient is having some conditions, they should start with infected endocarditis prophylaxis. So bronchoscopy and biopsy. Then apart from that, previously gastrointestinal and genitourinary procedures, routinely they used to do prophylaxis, give prophylaxis. Currently, it's been removed from the guideline. Last updated in 2013, ACHA. After that, it was not updated. From that, it's very clear that it's no longer need prophylaxis, genitourinary and gastrointestinal conditions. What therapy you give, that is also key. So we prefer oral drugs or IV drugs. So oral drugs means we usually use amoxicillin. IV drugs means you can use ampicillin. But if the patient has penicillin allergy, then in that setting, either for oral or IV, we can use clindamycin. Clindamycin is an alternative if the patient has penicillin allergy. You can use either amoxicillin, or if you want to use IV drug, then you can use, because many of the time it will be dental procedure or respiratory procedure, patient may be in NPO. In that setting, amoxicillin may not be that much valued if the patient is not able to eat. You can use IV ampicillin. Alternative to ampicillin is ceftriaxone, of course. Just 1 dose is enough. Or you can give a cefazolin IV drug. More than enough. Just 1 gram of cefazolin or 1 gram of ceftriaxone must be doing the job. So in general, we prefer ampicillin, amoxicillin if the patient is, are penicillin sensitive and penicillin, not penicillin sensitive, not penicillin allergic, we give amoxicillin or ampicillin. Clindamycin is an alternative if the patient is allergic to penicillin. Remember when to give prophylaxis, usually 30 minutes to 1 hour before the procedure. Just a single dose, 30 to 60 minutes or 30 minutes to 1 hour before the procedure, single dose is enough. Single dose of the drug is enough as a prophylaxis. Clear? Do you understand? That's all. Any other questions? Only one question. Management of stroke. Stroke. Once again, stroke is not a contraindication for surgery. First thing that you need to worry is stroke is basically not a contraindication for surgery. It's not a contraindication for surgery. Previously, it was a contraindication, but stroke is currently not a contraindication for surgery. In fact, if there is any systemic embolism, in a patient, you have to definitely do a surgery. Suppose, if the patient is having a systemic embolism, plus if the patient is having left-sided infected endocarditis, like a mitral valve or aortic valve, then you should do urgent surgery by the standard guidelines. Suppose if the vegetation is more than 1 centimeter, if the vegetation is more than 1 centimeter, then if there is an evidence of systemic embolism, 100% you need to go for a urgent surgery. Or if the patient is having a severe valvular dysfunction, like valvular regurgitation, if it's a left side embolus, then once again you need an urgent surgery in this situation. Or if the patient is having a recurrent embolus, recurrent embolism, in this setting, you can do surgery if the vegetation is more than 1.5 centimeter. That's all. So this is for recurrent embolism, if it's more than 1.5 centimeter. I don't think I'm going to start with, continue with cardio today, not even endo. My plan is to start with neuro. I'll take a poll at the end. If they wanted neuro, I'll start with neuro today. Depends on that. But most importantly, what you need to know, see, this will be only confusing because you asked, I told you. So I think this is not really needed. But what you need to know is in exam is stroke is not a contraindication for infected endocarditis. That's all, ideally speaking. So I think this must be okay, right? So stroke is never a contraindication. I think we have completed the infected endocarditis section as well, including the organism. Infected endocarditis is basically a very important topic for exams as well. So I'll tell you a few things which are important only for exams. Yeah, I think Monica has asked the right question. Organism causing fungal endocarditis. It can be Candida very commonly. Usual organism that produces fungal endocarditis is Candida. Where is that? If it's a fungal endocarditis, the usual organism that will cause is Candida only. There are rare species like Aspergillus also has been noted in certain case reports, but Candida is the usual common entity. And the risk factors for developing fungal infected endocarditis usually, once again, that bacteremia risk, especially when you have a HD catheter or any central venous catheter, you are going to have a bacterial, risk of developing a Candida infected endocarditis. All right. And one more point, which I forgot to tell about this fungal infected endocarditis. Whenever you have a fungal infected endocarditis, basically you give lifelong azole prophylaxis. Some azole like fluconazole or something, you have to give lifelong prophylaxis. Basically speaking, other areas like whatever conditions I told you, indications, you're only going to give prophylaxis for during certain procedures only. You're not going to give a lifelong prophylaxis. But as far as the fungal infected endocarditis is concerned, which is a very rare entity, you have to give lifelong azole prophylaxis, which is very, very important. So after knowing this, let me tell you a few important points only on clinical cardiology. So only few important points. I'm not going to beat around the bush because I'll discuss, if you are willing to attend 2.0, there I'll be discussing about more of clinical cardiology. So as far as clinical cardiology is concerned, to start with the blood pressure, the most important thing they'll be asking is your Valsalva response in exam. So remember, knowing about the blood pressure difference between two arms is important, but really, you're not going to do anything about that by knowing the same thing again and again. I don't really think that's important as well. So what are the causes of high blood pressure, what are the causes of low blood pressure, what are the causes of narrow pulse pressure, what are the causes of wide pulse pressure. And if you don't know that, there is nothing to attend the exam in the first place. These are very, very common things. But what is exam related importance and what are the topics that you have to concentrate where you cannot guess? One is the Valsalva response. That I feel is the most important, because that is what most students will forget, and at the same time most students is not going to study that. So you have 4 phases of Valsalva basically. So the first one is the first phase of Valsalva, and you have the second phase of Valsalva, then you have the third phase of Valsalva, then of course you have the fourth phase of Valsalva. So the first 2 phases we call it as something called a strain phase. The second last 2 phases, the 3 and 4 phases, we call it as the release phase of Valsalva. So what do you mean by strain phase? You ask the patient to do Valsalva. Like for example, let me do. That is strain phase. Now we released it. So after releasing, immediately the next 30 seconds is what we refer to as something called release phase of Valsalva. So why we are divided into 4 different stages? Because it's going to have 4 different responses. Let us see the normal response first. If you take, this is the normal blood pressure. This is normal blood pressure. If you don't do Valsalva, this is going to be the BP. If you do Valsalva, what will happen? In the phase 1, there will be a decline in the blood pressure from the normal BP. That's what happens in phase 1 of Valsalva. Then in phase 2 of Valsalva, why the phase 1 of, phase 1 of Valsalva will have an increased BP, usually. Why in phase 1 there is an increased BP? That is because of the increased intrathoracic pressure. Suddenly the blood is pushed out because of the increased intrathoracic pressure. That is why in phase 1, let me draw this again. In the phase 1, why it is showing like this? I'll connect from here, that's better. Okay, so you're having increased blood pressure in phase 1. That's what is going to happen in the first phase. And in the second phase, there will be reduced blood pressure. This is the phase 2 of Valsalva. In the initial phases, that is because of the increase in intrathoracic pressure, pushing of the blood that is present already in the thoracic cavity is going to produce a slight increase in pressure. Then you are going to have a reduction in the blood pressure. That is because of the reduced venous return. So once you increase the intrathoracic pressure, the pressure here is very high. So the venous return, because it's like creating a constriction and occlusion in the thorax. So the blood that is moving from the neck and the blood that is coming from the great veins through the IVC is going to reduce. Because the reduced venous return, you're going to have a reduced BP. So that's what's happening in phase 2. And then you have something called a release phase. During the release phase, once immediately you release, you're not going to result in increase in BP suddenly. So you'll be having a slight increase, but still it will be below par. And after some time, after 10 to 15 seconds, your BP will be persistently increase for a longer period of time. That is due to increase suddenly when you release, the venous return will increase after this point of time. And once again, you're going to have an increased blood pressure, which after some time, it's going to become normal and it's going to merge with the usual curve. This is a standard Valsalva response. So phase 1, I can tell increased blood pressure, which will be very brief. And then in phase 2, you're going to have a reduced blood pressure. That is because of reduced venous return because of occlusion at the thoracic level. And in phase 3, you will have a low BP, which will be brief as well in phase 3. And in phase 4, you will have an increased blood pressure due to increased venous return. So this is what happens in phase 4. So this phase 4 is what we refer to as an overshoot phase. That's very important because usually that will be a question in exam. They'll ask you in a cardiac failure, what will happen? In a patient who's having a heart failure or systolic dysfunction, you are not going to have any overshoot phase. You're not going to have overshoot phase. Suppose if you want to draw a curve of a patient who's going to have a heart failure, let me rub this and let me write, I draw the curve only. So what will happen in a patient who's having a heart failure? In a patient with a heart failure, they're going to behave something like this. They'll have the same standard kind of a curve that what you expect, but they will not have this kind of overshoot phase. So this is how the patient with heart failure will behave, especially heart failure with systolic dysfunction. They're not going to have overshoot phase. On the other hand, if a patient who's suffering from diastolic dysfunction, this systolic dysfunction, suppose the patient is having diastolic dysfunction, they'll follow something called a square wave kind of a scenario. The BP will rise, and even during the strain phase, the BP will not come down at all. And during the phase 3, the BP will come down and they will merge with the usual curve. So which means this kind of square wave response. So this kind of square wave response, this is what we call square wave response. This kind of response you will be getting in patients with diastolic dysfunction. That is because if the heart cannot relax properly, your pressures will be subsequently higher throughout the cardiac cycle. So that is what yesterday we have studied that, not yesterday, day before yesterday we have studied in heart failure with preserved ejection fraction, there will be diastolic dysfunction. That is the one that's going to increase the end diastolic pressure. So because of that, they'll be having this kind of a square wave kind of a response. So this is what is going to happen in a systolic diastolic dysfunction. You can write it as square wave response. So this is point number 1 as far as the blood pressure is concerned. So apart from this, you need to know what are the conditions that cause low pulse pressure, what are the conditions that cause high pulse pressure, what are the conditions that produces difference in blood pressure between the arms and the legs. So these are very basic things which you should definitely be knowing by now. So can you tell me, list out the conditions which can cause asymmetric BP between upper limb and lower, between two upper limbs or between upper limb and lower limb? First, tell me the condition that produces difference in BP between two upper limbs. Upper limbs and lower limbs, coactation is fine, but I'm asking about two upper limbs. First cause, acute, is always dissection. Dissection, acute. Okay, between upper limb and lower, two upper limbs. Then between two upper limbs, what else? Okay, Takayasu arteritis or any condition that produces aortitis, fine. So any vasculitis that produces aortitis, in general Takayasu arteritis. Third, yes, any condition that produces thoracic outlet syndrome, correct? Fourth, no, I don't think so. Compound syndrome is not a logical answer. Thoracic outlet syndrome is fine. Then, between two upper limbs, subclavian artery aneurysm. Okay, any obstruction in the subclavian artery or aneurysm in the subclavian artery or subclavian artery thrombus, yes, possible. Then fifth, this is the most important. Yes, Saurabh told correctly. That's what I'm expecting. That's what is the exam question. Supravalvular aortic stenosis, where preferentially the blood flow will be towards the right side. So the right upper limb will receive more blood. That is because of something called a Coanda effect. Then supravalvular AS. Whenever I tell supravalvular AS, you have to think about Williams syndrome, isn't it? So supravalvular AS is one cause. So 5 causes you have to know about BP difference between two upper limbs. One is dissection. That should be the standard. Second is the vasculitis, especially Takayasu arteritis. Third thing is the supravalvular aortic stenosis. Fourth is thoracic outlet syndrome, and fifth is subclavian artery aneurysm or subclavian artery thrombosis. Then apart from that, you have BP difference between upper and the lower limbs. If you have BP difference between the upper and the lower limbs, you can tell the same conditions, but supravalvular aortic stenosis doesn't make any sense there. If you really want to tell, you can tell, but I don't really want to tell supravalvular AS and get caught with the examiner. And if you want to add one more, you can add coactation of aorta. Aortic regurgitation, it's not true sign because you're talking about Hill sign. Many students are talking about Hill sign where there will be a difference between systolic blood pressure of the upper limb and the lower limb. But in a true sense, only in sphygmomanometry you will see that difference. In intra-arterial recordings, you don't see that much difference. So Hill sign is basically considered to be a sphygmomanometric artifact. It's not a true sign. So you can keep it as the last. So I'll tell the same things what I've told you for difference between upper limb and lower limb. But most importantly, I'll be telling arterialization at the last, if at all the examiner expects, but coactation should be on the top because coactation and dissection is very, very important in that scenario between upper and lower limbs. Some people are telling thromboangiosis obliterans, Berger's disease, but for that matter, any vascular disease can cause the difference now. So that's not what the examiner will expect. Technically speaking, yes, correct. That's why you do something called ankle brachial pressure index or an ankle brachial index, where the arm BP will be more than the leg BP. Fine, you get a difference. But technically speaking, it's not only the TAO that should cause the difference. It should be all the peripheral vascular disease. Any atherosclerotic problem also should cause the difference. So technically, that's not very, very important when you're answering the question in front of the examiner. See, between two upper limbs means they will expect, Takayasu arteritis, then dissection, then supravalvular AS, remaining whatever you want you tell. Difference between upper and lower limbs, generally they will expect coactation additionally. Then they'll expect this dissection as the two most important things. Remaining whatever you want you can tell, no problem. So this is very important. And how will you calculate pulse pressure? Williams syndrome, now short note, why you need Williams syndrome? As far as I'm concerned, in exam, Williams syndrome only 3 points. It's a triad. Hypercalcemia, Elfin phases, supravalvular aortic stenosis. That's all. Nothing else is needed. You can attend 2.0 if you want to know Williams syndrome better. Then, how will you calculate the pulse pressure? Is there any way to calculate pulse pressure? How will you tell it's a pulse pressure is normal or pulse pressure is abnormal? Actually, according to many standard textbooks, yes, this pulse pressure is equal to systolic blood pressure minus diastolic blood pressure is basically wrong. This is not the current idea. This is only very old idea. Current idea is something called a proportionate pulse pressure. This is the true pulse pressure, where you basically take the pulse pressure divided by systolic blood pressure, which means you see what is the percentage of pulse pressure that is compared to the systolic blood pressure. If the pulse pressure is less than 25% of systolic blood pressure, that is considered to be narrow pulse pressure. If it is more than 50% of the systolic blood pressure, then it's considered to be wide pulse pressure. So which means it should be based basically on the proportion of the systolic blood pressure only. This kind of things will unnecessarily overestimate or underestimate things. For example, if the BP is 80/60, so here the pulse pressure is only 20, which you cannot call it as narrow, because that may be appropriate for that particular pulse. Suppose the pulse is 180/130. So this could be a narrow pulse because the gap compared to the systolic blood pressure is actually quite less. So even though the pulse pressure here is 50 according to your old definition, this is not appropriate because this still it might be a narrow pulse pressure depending on the systolic blood pressure elevation. So this is not a correct one. So this is the correct thing. That's the ideal pulse pressure technique to measure. That is called proportionate pulse pressure. No, I mean, if you want to talk about pulse, you can keep on talking about pulse. But let me tell you about some of the important characteristics of the pulse only, that is important as far as the exam is concerned. So what are the important characteristics of the pulse basically? What characteristic of the pulse that you need to know? Carotid pulse. 2.0 later on. So not volume, we are talking about the character. Volume is separate from character. See, whenever I talk about clinical cardiology, you will be completely messed up. It's very difficult to answer my questions. You can answer all the theory questions, but when it comes to clinical cardiology, it becomes really difficult. So character, a lot of characters are there. So for example, in exam, they will be asking you certain important characters, like they'll be asking you more on the Bispherians pulse. They'll be asking you where you get the jerky pulse, which is nothing but a variant of Bispherians pulse. It's a variant of Bispherians pulse only. Then they'll be asking about pulses parvus et tardus. There's a slow racing pulse with a sustained peak. Then you have the classic water hammer pulse or collapsing pulse, or otherwise referred as Watson's water hammer pulse, or we can call it as a collapsing pulse. Then you have other double peaked pulses, one in systole and one in diastole, called as dicrotic pulse. So where you get all this? So as far as Bispherians pulse is concerned, remember these are double peaked pulses basically. So Bispherians and jerky. So I can write like this. Double peaked pulses. So dicrotic is also double peaked pulse. Where will you get a dicrotic notch? Here you can see. I mean, before that you need to know the normal pulse. Normal pulse looks something like this. Normal pulse nature is called to be catacrotic in nature. That's the nature of a normal pulse. That's how normal pulse looks like. And this is the tidal wave. And sorry, this is the percussion wave that you percuss basically. And this is the tidal wave. And this is the dicrotic wave. And this notch is what we refer to as a dicrotic notch. And each and everything has a reason why they happen. So dicrotic notch will happen only when you cross the pulmonary valve, in the sense, or aortic valve, which means only when you cross the semulunar valves, you get the dicrotic notch. So whenever you get a dicrotic notch in a pulse tracing, means the blood has crossed the semulunar valves. That's what it means. So this is very important in catheters also. So this is a normal pulse, which is catacrotic in nature. So during the systole, if you get two peaks, double peaked pulse in systole, if you get two peaks, it can be either a Bispherians pulse or a jerky pulse. Typically, if you want to know about Bispherians pulse, it is typically seen in the setting of severe aortic regurgitation or a AS and a AR combined together. But remember, one important point to notice, in AS alone, you don't get a, even in severe AS, you don't get a Bispherians pulse. Double peaked pulse is not possible. Or if you want to know jerky pulse, remember sometimes jerky pulse is compared to that of Bispherians pulse. There are subtle difference between jerky pulse versus Bispherians pulse that happen in the setting of an HOCM. HOCM produces a jerky sort of a pulse, but only difference is whether these two peaks are equal or not. Remember, in Bispherians pulse, they will be unequal. In jerky pulse, they will be equal. That's all. That is the only difference, but both are double peaked pulse. So in exam, see very carefully. If they're given Bispherians pulse and if they're given HOCM also, then that also comes into that clinical picture. That's correct. That's not a problem. If they specifically gave jerky pulse, then you can go for HOCM. Otherwise, jerky is that nothing but a variant of Bispherians pulse. That's all. Then if you talk about dicrotic pulse, you will get one peak in systole and one peak in diastole. This is what we refer to as something called a dicrotic pulse. So this kind of pulse typically you will be encountering in the setting of a sepsis. That's where you encounter typically. In any sepsis, you can encounter dicrotic pulse whenever the systemic vascular resistance is very low. So you can encounter in that setting. Or sometimes in failure, heart failure, you can encounter. But more importantly, exam point is IABP. That is intra-aortic balloon counterpulsation. This is a very common question exam where you can see dicrotic pulse, which means a diastolic augmentation. I told you already in intra-aortic balloon counterpulsation, you are going to inflate the balloon in diastole. When you inflate the balloon in diastole, the diastolic pressure will increase. Because of that, your dicrotic notch will peak up. The dicrotic wave will become bigger. So that's very, very common question. Understandable also, IABP, because the balloon inflates in diastole. So that's typical dicrotic pulse. And you get something called a pulsus alternans that is based on the Frank-Starling principle. I'll write alternans. Based on the Frank-Starling principle, pulsus alternans is typically seen in severe left ventricular failure. Very classic. And pulsus parvus et tardus, it's a slow rising and sustained peak seen typically in severe aortic stenosis. And Watson's water hammer or collapsing pulse is very simple. You're going to see that in severe aortic regurgitation. You know what do you mean by Watson's water hammer pulse? Watson's water hammer is sudden rise with a rapid fall. So this is what we refer to as a collapsing pulse, which means it's very difficult to see a dicrotic notch here. There will be a rapid rise that followed by a rapid fall. So that is Watson's water hammer pulse. You do not have that kind of a smooth rise and a smooth fall. There will be a sudden rapid rise and aside with a rapid fall. It hits you very hard. That peak wave hits you very hard. That's what we refer to as a collapsing pulse or a Watson's water hammer pulse, sign of a severe aortic regurgitation. And you have something called a pulsus paradoxus. Remember, pulsus paradoxus should be ideally explained in the blood pressure zone, BP, because even though it's called a pulsus paradoxus, it's seen in the, it's actually found through the blood pressure only. So idea is, why they called it as pulsus paradoxus in the first place? Why they called it as a pulsus paradoxus? What is the reason why they called it as a pulsus paradoxus? It's not a misnomer because Indian textbooks give it as a misnomer, but it's basically not a misnomer. Basically speaking, pulsus paradoxus is systolic blood pressure fall more than 10 millimeters of mercury during inspiration. That is what we refer to as pulsus paradoxus. Ideally speaking, if you take normal setting, I'll give a mnemonic called right and a mnemonic called left. This is a mnemonic I generally used to give. If you take inspiration, when you take inspiration, the right-sided flows will increase. Right-sided flows will increase. The right-sided filling will increase whenever you take inspiration. And all pressures will drop during inspiration. All pressures are going to decrease during inspiration. In the sense BP will decrease during inspiration. JVP will decrease during inspiration. So when I write I, I'm going to write like a down arrow, down like this. I don't know who's going to write I like this, but I generally remember like that. I'll be writing like this. So I'll put an arrow like this, which means it's going to come down. I mean, that's how I remember. It might be stupid, but that's how I remember right-sided all pressures. Right means inspiration. During that flow will increase, but all the pressures is going to decrease. You can understand very clearly here. During inspiration, the intrathoracic and even the intrathoracic pressure will fall. Intrathoracic pressure will fall, JVP will fall, everything will fall. The reason is because when you suddenly expand during inspiration, the blood is going to fall more into the thorax because the volume increases. By Boyle's law, pressure should drop. So this negative pressure is going to suck the blood from the other areas. And you can easily remember that as far as JVP is concerned, JVP is like a column here, column of blood here. When you expand, when you increase the volume, it can fall down into the heart. So of course, the right flow to the right heart will increase for sure. But your JVP will definitely fall. And because the lungs are expanding, the capillaries will become big, the pulmonary capillaries, because lungs are expanding there. So they can accommodate more volume. So flow to the left side is also less. So your blood pressure is also going to decrease. So what's happening is during inspiration, intrathoracic pressure is decreasing, JVP is decreasing, flow to the right side is increasing, flow to the left side is decreasing. So the BP is decreasing. So these are the things that are happening, which means all pressures are dropping. Only one thing that is increasing during inspiration is flow to the right side is increasing. So you can imagine, remember by the mnemonic called right. Whenever you talk about left side, the opposite will happen. In the left side, during expiration, your flow on the left side will increase. Left-sided flow will increase. But on the other hand, all pressures will increase. All pressure will increase. Like for example, BP will increase, JVP will increase. Intrathoracic pressure is also going to increase. This is very simple because whenever you produce expiration, the intrathoracic cavity size will decrease. And because of that, your pressure within the thorax will increase by Boyle's law because volume is decreasing. So it's like producing more pressure, cutting off the blood at the JVP level itself. So the blood cannot come down. So it starts accumulating and the JVP starts rising. So of course, during expiration, the capillaries collapse in the lung so that the blood, whatever that is present within the pulmonary capillaries will be pushed through the pulmonary veins into the left atrium and left heart. So the BP will start rising during the expiration. So this is what happens. So normally itself during inspiration, blood pressure is going to fall. So finally, that is what I'm going to tell. So normally itself, BP is going to fall during inspiration. But pulsus paradoxus is an exaggerated fall in the blood pressure during inspiration. That is more fall in the systolic blood pressure during inspiration is what we called as pulsus paradoxus. And to be honest, why they called it pulsus paradoxus is correct during their time, because what they found out is, for example, one condition that produces pulsus paradoxus very commonly and routinely is cardiac tamponade. That's fluid that is compressing on the heart. Cardiac tamponade can produce pulsus paradoxus. Because cardiac tamponade produces pulsus paradoxus, what they found out is suddenly BP falls during inspiration in pulsus paradoxus to more than what it should happen. So during the inspiration, what they found is pulse was not felt at all. Because the BP is dropping, they couldn't feel the pulse. So when they see the auscultation, when they looked for the heart sounds was there during inspiration. But suddenly, only during inspiration, pulse was not there. That is because of a dramatic fall in the systolic blood pressure. So it was a paradox for them. Heart rate there, but pulse not felt. So that's why they named this as a pulsus paradoxus. During their time, it was a correct name only. It's not like a misnomer and all. So what you see is that's why they named it as a pulsus paradoxus. They didn't call it as a BP paradoxus. If they have called it as a blood pressure paradox, then what you say is correct. So then it could be a misnomer. They called it as a pulsus paradoxus only. So that's a correct terminology only. So best example for a condition which can produce pulsus paradoxus is cardiac tamponade. It can be seen in a massive pulmonary embolism. It can be seen in a right ventricular myocardial infarction. So 25% cases of constrictive pericarditis can show pulsus paradoxus, but in exam, usually the answer will go towards a cardiac tamponade only. Everyone knows that. But many other conditions can also produce, even severe bronchial asthma or acute severe bronchial asthma can produce pulsus paradoxus. So another very common question exam is acute severe asthma can produce pulsus paradoxus, where it has studied one of the criteria for diagnosing acute severe asthma is presence of pulsus paradoxus. So these are the two conditions they'll be asking you in exam. Remaining things, if you want, you can remember. 25% of constrictive pericarditis also produces pulsus paradoxus. But in exam, please don't answer unless until it's specifically asked for. And this is what is going to happen. Remember, pulsus paradoxus is basically measured through blood pressure readings only. BP, using sphygmomanometer only, you have to measure pulsus paradoxus. You need to prove that the blood pressure falls by more than 10 millimeters of mercury during inspiration. So which means the method has been asked once in AIIMS in 2019, I think. They asked the method how to find out the BP, where it's very clear the patient should do normal breathing. That's the most important point, how to measure pulsus paradoxus. The patient should not breath hold, or the patient should not maintain the breath in expiration. So similarly, if you maintain the breath in inspiration, that's not a right technique, or if you maintain the breath in expiration, it becomes a Valsalva automatically. You try doing that, you maintain the breath during expiration, it becomes a Valsalva kind of practice. So you will actually get a Valsalva waveform if you maintain the breath in inspiration or if you maintain the breath in expiration, and that will not really tell you the pulsus paradoxus. So don't do that. The patient should breathe normally to achieve to find out the normal pulses paradoxes. That's a very important question as far as exams are concerned. So that's all about the pulse that you're going to get in exam. And people are asking about JVP. I'll tell you in a short way about how JVP's waveforms are important. As far as JVP is concerned, the waveforms will look something like this. This is very important to understand. Remember, this is the A wave, and we're getting two peaks, isn't it? A wave and the V wave. So remember, of course, the image what I've drawn is very important. A wave is always taller than the V wave, and we know why the A wave is happening. A wave is due to atrial contraction, and V wave is basically due to venous filling of the atrium. So that is coming from the great veins, that is SVC and IVC. Then of course we have some other depressions also. One is called the X descent and second is the Y descent, of course. I mean, as I've drawn in the image, X descent is more steeper than the Y descent normally itself. So X descent basically happens due to ventricular contraction, especially during the rapid ejection phase. Rapid ejection phase, you get this X descent. That is due to when ventricular contraction happens, they pull the tricuspid valve on the atrial floor down so that they increase the volume of the atrium transiently. So that increased volume by Boyle's law is producing a negative pressure. That's why you're getting this curve. So anything that produces rapid ventricular contraction, even a simple tachycardia, can produce a prominent X descent because of the rapid ventricular contraction. And Y descent is due to ventricular filling, not due to venous filling. So when the atrium empties its blood into the ventricles, during that time, once again, the pressure is going to drop and you're going to get a Y wave, Y descent. And C wave, we know why you get, that's not really important for us. C wave usually happens due to isovolumetric ventricular contraction. That's the time. That is due to movement of the tricuspid valve transiently into the atrium that bulges out. So that's the reason for C wave. Previously, they thought why they named it C wave is because they thought it's due to carotid artifact. So they thought like that carotid pulse is the one that's causing an artifact in the JVP to produce the C wave. But as far as I know, and the textbooks are giving, C wave is not due to carotid artifact, as they originally thought it's due to isovolumetric ventricular contraction. So A, V, X, and Y are the most important as far as we know. Other things on C wave is not really important. Suppose let us see the abnormalities of the A wave first. Whenever you don't get an A wave, typically in exam, you're going to answer it's an atrial fibrillation. I told you the 4 no's in atrial fibrillation, that one of the no's is no A wave in the JVP. Then you have a prominent A wave. So prominent A wave, you'll be typically getting the setting of pulmonary hypertension very commonly. And second is in tricuspid stenosis, where the atrium tries to push more blood against the stenosed orifice. The contraction should be powerful. And at the same time, in pulmonary hypertension, the right ventricle would have hypertrophied and it will be non-compliant. So left atrium tries to contract forcibly against a non-compliant right ventricle in pulmonary hypertension. So in these conditions, you'll have a prominent A wave. But more importantly, you will get a Cannon A wave. So we can call it as a Cannon A wave here. So whenever you get a Cannon A wave, you need to first of all think about two important things. One, whether you're getting a regular Cannon A wave or you're getting a irregular Cannon A wave. So first of all, the basis of how you get a Cannon A wave is important. So Cannon A waves are there whenever atrium and ventricle are contracting together. When atrium and ventricles are contracting together simultaneously. So that is the place where you'll get a Cannon A wave, because atrium now has to contract against a closed tricuspid valve or closed mitral valve. So that time only you will get a Cannon A wave. So regular Cannon A wave, you can easily understand. Typical example is a supraventricular tachycardia, that is SVT. So typical example is an AVNRT, where you can get a regular Cannon A wave, where I told you atrial complexes and ventricular complexes happen together. That's what we have been discussing, this pseudo S pattern. If you remember pseudo R pattern, I think you will be remembering all these things. Why these are all happening? Because of the superimposition of the POS and the QRS most of the time. So that is the reason why, in fact, during every beat, the P wave and QRS will come together. So that is why, which means indirectly your atrial and ventricular depolarization contraction happen together. That's why the best example is in AVNRT, where you'll get a regular Cannon A wave. Whenever you get an irregular sort of a Cannon A wave, I am very sure there is going to be an AV dissociation. Because in AV dissociation, the P waves will be sprinkled over throughout the ECG, I told you. And some of the P waves will fall over the QRS complexes. We know that if some of the P waves falls over the QRS complexes, during that point, you will result in a Cannon A wave. So this AV dissociation can be associated with the bradycardia. We know that the bradycardia that is commonly associated with AV dissociation is complete heart block. That's a cause. And if it's associated with the tachycardia, we're going to talk about a ventricular tachycardia or even any other ventricular premature contraction. Junctional rhythm can cause Cannon A waves. Yes, it can cause, depending on where it is originating from. So depending, you have to compare with the ECG also. So sometimes in junctional rhythm, you can get P waves before the QRS also. Junctional rhythm is sort of a sandwich kind of a thing. And only with advanced ECG understanding, you will know what is junctional rhythm. Junctional rhythm is a completely different entity. You should not confuse with AV and RT. And at the same time, junctional rhythm can produce P wave before the QRS, after the QRS, and even over the QRS, but regularly, not like VT, like AV dissociation. So it depends. It can cause Cannon A waves, but I'm telling about the best example is AV and RT is going to be the best example, which produces a Cannon A wave most of the time. So many conditions can produce Cannon A wave. So in exam, you need to remember only 3 conditions: AV and RT, complete heart block, and ventricular tachycardia. And if you see these kind of regular Cannon A waves in both the sides, both the jugular veins are showing regular Cannon A waves in AV and RT, that specifically referred to a clinical sign called as Frock sign. So why you call Frock sign? Because both the JVPs with every beat will enlarge simultaneously. That's why we call that as something called a Frock sign. That's a clinical sign that translates. So these are the abnormalities of the A wave, basically. Then you can get this X descent. Now we'll move on to the X descent. What are the problems of the X descent? So what will cause X descent issues? So only thing I wanted is where will you get a rapid X descent? Rapid X descent. Rapid X descent. Yes, rapid X descent is typically seen in a condition called cardiac tamponade. Cardiac tamponade is a condition where you'll get a rapid X descent, even though you can get in constrictive pericarditis. Rapid X and rapid Y both can be seen, prominent X as well as Y in constrictive pericarditis. But in general, rapid X descent is a feature of a cardiac tamponade only, basically speaking. And usually we used to give an age-old mnemonic called as PATAX that's been there since from my time. I think Naveen has told already. So tamponade basically generates deep X descent, and constrictive pericarditis basically generates a deep Y descent. So this is a mnemonic, that is PATAX, deep Y descent, so or a rapid Y descent. So this is PATAX. So you can answer this rapid X descent in a tamponade. So when you have a blunted X descent, blunted X or an absent X descent, typically you're going to answer tricuspid regurgitation. That's the first thing that you have to answer. Yes, of course, tricuspid regurgitation. Then talk about Y descent now. Y descent, whenever you have a rapid Y descent, of course we know the answer, it is constrictive pericarditis straight away. That's going to cause a rapid Y descent. And then you have this kind of blunted Y descent. Blunted Y descent, you get in tricuspid stenosis, basically. And even you can get this kind of blunted Y descent in other conditions like myxomas and all, but tricuspid stenosis is going to be the most important. Blunted Y descent, you're going to get tricuspid stenosis because the ventricular filling will be restricted there. That is the reason in tricuspid stenosis. And what about V wave? V wave, we're talking about a large V wave. Large V wave, one answer is tricuspid regurgitation. This is the most common answer they will expect. And most of the times, if you talk about tricuspid regurgitation, we need, I mean, they can give you some waveforms and they'll ask you what will be the waveform. For example, if you get a waveform, something like this, for example, you have a A wave, you have a CV like this, and you have a wave, you have a CV like this. So if I draw like this is A, C, V, Y, A, C, V, Y. So what is this? What is this? Yes, this waveform is equal to tricuspid regurgitation. I mean, they can give some image-based discussions like this also. They can give some things like this, and they can ask, what is this? So this is a typical tricuspid regurgitation where you see, it's a severe in fact, because you see something called a CV fusion. So this is very characteristic. CV fusion. And this will clinically translate into an important sign called as Lanczynski sign. So what do you mean by Lanczynski sign? Lanczynski sign is that whenever there is a tricuspid regurgitation, that regurgitant jet going into the atrium during the systole will blunt the extensor, because during the systole, the pressure in atrium should go down because the floor is pulled down. But here, because the amount of blood during ventricular systole, the X wave will be completely obliterated, and your CV fusion will happen. The V wave will be too much because V wave is due to atrial filling. But here, actually, atrium should be filled during ventricular systole only from the veins, great veins. But in a tricuspid regurgitation, atrium is filled from the great veins. At the same time, ventricle is also filling the atrium. So because the atrial filling is increased in tricuspid regurgitation, the V wave becomes very prominent. So X obliteration with V descent will result in CV fusion, and that will produce a very big kind of a CV wave, and that will actually try to lift the earlobes. And you can see the earlobes will move forward with every pulse, every beat. And that's typical of a tricuspid regurgitation, and that's what we refer to as a Lanczynski sign clinically. So that's nothing but due to a CV fusion. And if you see something like that, so for example, if you see a big A wave, like a bigger A wave like this, and you have a C wave, and you have an X descent, then you have a small Y, and then you have a bigger A wave, X descent, and a smaller Y. What is this typical of? So A, C, X, V, Y. This is tricuspid stenosis, where you get a large A wave with a small Y descent. That is characteristic of a tricuspid stenosis if you get some waveforms like this. Okay. Then the third waveform, which you, I mean, it can happen in any condition that produces right ventricular hypertrophy, like pulmonary hypertension also. So it's not like it's seen only in TS. In exams, they will ask you about TS, but it can happen in any condition that, like increases, I mean, reduces the right ventricular complaint. So like right ventricular hypertrophy, and pulmonary hypertension is also going to do the same thing. And third waveform, which I can draw probably is on constrictive pericarditis. So where I can draw an A wave and a prominent X descent. X also will be prominent in constrictive pericarditis. And then I can draw a small V wave with a Y descent, and an X wave, A wave, X descent, small V wave, Y descent. So if they show this kind of a situation, what is this thing? Anyone answer? So A, maybe C here, but I'm not drawing X, V, Y, A, X, V, Y. So what is this? What is this waveform? Where will you see this kind of JVP? So what is this? This is typical of a constrictive pericarditis in exam. So if they show this kind of image, it must be constrictive pericarditis. And please understand, so they can give this kind of M or W. So this looks like a, probably if you see the highlighted part, it looks like either a M or a W. So if they give you JVP showing M pattern or a W pattern, then again it means it's a constrictive pericarditis only. Of course, restrictive cardiomyopathy also can produce a similar picture, but in exam, standard is to answer only constrictive pericarditis. That's all. This is the answer. And as far as JVP is concerned, you need to know about what do you mean by Kussmaul sign. Kussmaul sign is inspiratory increase in the blood pressure. That is Kussmaul sign. Basically, inspiratory increase in JVP. That is Kussmaul sign. Normally, JVP should reduce during inspiration, but if JVP increases with inspiration, that is Kussmaul sign. So typically, Kussmaul sign can be seen in many conditions, but typical in constrictive pericarditis, it can happen in right ventricular myocardial infarction. It can happen in tricuspid stenosis. It can happen in massive pulmonary embolism. It can happen in myxomas of the right ventricle, right atrium, right atrial myxomas. So severe right heart failure. And even 25% of cases of tamponade can produce Kussmaul sign positivity. But remember, as far as the traditional understanding is concerned, Kussmaul sign, constrictive pericarditis, and pulsus paradoxus is cardiac tamponade. This is what we have studied. But remember, 25% of the case of constrictive pericarditis may have pulsus paradoxus, and 25% of cases of tamponade also may have Kussmaul sign. But in exam, it's always constrictive pericarditis should be the first answer as far as Kussmaul sign is concerned. Apart from that, finally, you have hepatojugular reflex. What do you mean by hepatojugular reflex? What do you mean by hepatojugular reflex? Not liver push, exactly where you press is take a midline and immediately, like umbilicus is there, just to the right of the umbilicus, just 2 centimeter above, 2 centimeter to the right of the umbilicus and 2 centimeter to the above the umbilicus, you are actually pressing the abdomen. And once you press the abdomen, idea is to not press the liver. Idea is to press the IVC. That's what trying to do. When you press the IVC, you are pushing the blood into the heart, towards the heart, because IVC's movement is towards the heart. So it's like you are giving a challenge to the heart by producing more volume. So hepatojugular reflex is normal if the increase in JVP is less than 3 centimeter and that increment is there only for less than 15 seconds. So this is normal response, normal hepatojugular reflex. Suppose if you have a increase in the JVP for more than 3 centimeter, plus if it is sustained for more than 15 seconds, so this is the sign of a abnormal hepatojugular reflex. Remember, both criteria should be there. It should be increased by more than 3 centimeter and it should be sustained for more than 15 seconds. So this indicates a occult right ventricular failure. Of course, if the patient has overt signs of right ventricular failure, like hepatomegaly, pedal edema, ascites, this test becomes completely nonsensical and you need not really do this test. So the patient is having a normal JVP and you're suspecting an occult right ventricular failure. In this setting, this test will be very useful because that will tell you that the right ventricular wedge pressure will be more than 15 millimeters of mercury. That's what it's going to tell. So that's a good test, basically. So in occult failures, so in overt failures, this is really not needed. So this is hepatojugular reflex. Mostly they will ask you where you will see an absent response, which means there is no JVP elevation. If you have a patient with a what? Yes, any SVC obstruction. Any patient with SVC obstruction, you will not be having a hepatojugular reflex at all, because the like JVP should be transmitted through the SVC only. If the SVC is occluded, JVP will not elevate no matter what you do. You will not see anything. So that's a very logical thing and understandable thing only. See, any SVC obstruction will have an absent hepatojugular reflex in the first place. Then quickly I will tell you about the murmurs only that are important for exams, not important for anything else. As far as the murmurs are concerned, you can divide into systolic murmurs, diastolic murmurs, and you have a continuous murmurs. And remember, usually they won't ask you the grading in exam and all. Grading usually they won't ask in exam. So remember, grading, there is something called Glenn and Levin grading. Glenn and Levin grading and classification system is there. That is the system that you have to use, where you have grades 1 to 6 for systolic murmurs, 1 to 6 for systolic murmurs, and grades 1 to 4 for diastolic murmurs. Please study. Usually they won't ask it. Yes, NEET exam only. Usually they won't ask these gradings and all, but just for exams, if you want to attend practical exams, you can study. Otherwise, it's not needed. Remember, anything more than equal to grade 4 will produce a thrill also on palpation. These are some of the important points. So 1 to 6 for systolic, 1 to 4 for diastolic. Anything more than 4 is going to produce a thrill, basically. So systolic, diastolic, and continuous murmurs are there. And one UHA is asking IVC obstruction can produce. Depends on the level of IVC obstruction. If the level of IVC obstruction is in the below the area where you are pressing, still you may be able to get a epidojugular reflex. And remember, where the area where you are pressing the IVC is very close to the right atrium. So I don't think obstruction there really matters. And that's not a common, I mean, you can argue. See, anything in medicine can be argued. It's not like you cannot argue because there are multiple levels in the body. You can argue with anything and everything in medicine. You cannot tell no or you cannot tell yes. But it's all about giving sensible answers. If you tell IVC obstruction, you can argue, but nobody will like it. SVC obstruction is the classical thing, where you don't get the epidojugular reflex. So systolic, diastolic, and continuous. Systolic murmurs can be early systolic murmur or a mid systolic murmur or a late systolic murmur, or even it's a holosystolic murmur or a pansystolic murmur. That's called a PSM. So you know the cause of pansystolic murmur. It's going to be MR, TR, and VST. Classic conditions that produce a pansystolic murmur. As far as the early systolic murmur is concerned, usually acute MR, especially due to papillary muscle dysfunction, papillary muscle rupture, which happens typically in the setting of a myocardial infarction, especially infraposterior wall MI. We talked about already. Infraposterior wall MI to producing posteromedial papillary muscle rupture will produce acute MR. That because of the poor left atrial compliance, only early period the jet will move, and that's what we call as the early systolic murmur. And mid systolic murmur we also called as ESM. Other name for that is ejection systolic murmur. Typically happen in the setting of a AS and a PS, that is aortic stenosis and a pulmonic stenosis. And if at all you want to write, you can write HOCM. Other flow murmurs that can produce ejection systolic kind of qualities, your ASD also can produce. But remember, the murmur you get in ASD is basically not a typical organic murmur. It's actually a flow murmur. You have to be very clear about that. Even in TOF, you will get an ESM in the pulmonary area. And in TOF, why you get ESM in the pulmonary area is basically the flow murmur you get. And that's not an organic murmur, to be precise. And as far as late systolic murmur is concerned, typically you will get in MVP with MR. So remember, in mitral valve prolapse, initially the mitral valve will hit normally. Then after that, it will prolapse and it will produce a click. And after the click only, it will open up. It will regurgitate, producing a last stage only of the systole, and it will produce a murmur called as late systolic murmur. That is characteristic of MVP with MR. And as far as diastolic murmur is concerned, you have a mid diastolic murmur and an early diastolic murmur. Mid diastolic murmur typically you will get in MS, TS, and you can get in a type of murmur called Carey-Coombs murmur, which is happening in acute rheumatic fever. And you can get an Austin-Flint murmur that happens in severe aortic regurgitation. And EDM, early diastolic murmur, typically you will get in aortic regurgitation and pulmonary regurgitation. If you get pulmonary regurgitation due to pulmonary hypertension, severe pulmonary hypertension, that is what we refer to as something called a Graham-Steels murmur. We know that. And as far as the continuous murmurs are concerned, many conditions are there which can produce continuous murmurs. But of course, in exam, you talk about PDA that produces a missionary kind of a murmur, patent ductus arteriosus. Then we have coronary AV fistula, which can produce. Then rupture of sinus of Valsalva is there. That is called RSOV. Can produce. Then truncus arteriosus can produce. Then many other conditions are there. So which can produce this kind of a continuous murmur. In the exam, usually it will be limited to this only. So one more murmur that can produce in the early diastolic phase, that is called, you are going to tell what is the cause. So in LAD stenosis, you will get a murmur. What is that murmur called as? You will get an early diastolic murmur only there, but that's not important. But just for, namesake, I'm telling you that. What is the murmur? In LAD stenosis, you can get an early diastolic murmur because LAD's flow is predominantly happening during diastole only, left antidescending artery flow. It's predominantly happening during diastole. That's why you'll get a murmur there. What is that murmur? Anyone? Yes, that's called a Dock's murmur. Dock's murmur, that happens due to LAD stenosis. And you can get an MDM murmur in complete heart block. That's called a right arms murmur. In complete heart block, you might sometimes get a MDM-like appearance, mid-diastolic murmur. That's something called as a right arms murmur. So as an undergrad, if you know this table itself is more than enough, coupled with that Glenn and Levin grading, if you know that, that's more than enough to pass any exam as an undergrad. As an undergrad, this is the usual area where you miss. You will confuse in exam, especially in practicals about the MDM versus EDM versus PSM versus LSM, ESM, all these things will confuse in exam. If you don't get confused and if you answer these things clearly in exam, that's more than enough as an undergrad. Even for NEET PG exam, this must be more than enough. They're not going to ask anything more. Even though I will be discussing about how to differentiate between MRTR and VSD using the pansystolic murmur in the 2.0 class, and we can discuss about the MDM differential diagnosis in the 2.0 class. But right now, as far as NEET is concerned, that becomes completely pointless and nobody is going to ask those things. And as far as the hard sounds are concerned, you have two, S1 is there and S2 is there, S3 is there, S4 is there. First, as far as S1 is concerned, the most important thing is the intensity of S1. That is the most important. As far as S2 is concerned, the split is going to be the most important, more than the intensity. Even though intensity is also important, but as far as S2 is concerned, in exam usually they'll be thinking about the split only. When you take the intensity of S1, so S1 can be loud or S1 can be narrow. Clear? Sorry, soft. S1 can be loud or S1 can be soft. So conditions that produce loud S1, very simple. First you're going to answer MS and TS only. Those are the conditions that produces loud S1. Remember, but usually the loudness depends on many things. One is whether the valve, what is the left atrial pressure? More left atrial pressure will produce loud S1. That's one. But that's not the only thing that determines. Because whenever you have a more left atrial pressure, the valve will open for a long time, long distance. Once they open for a long distance, they close from a long distance, means they're going to hit with a more force. So probably that is one reason why you get a loud S1. Second reason is whether they're having adequate coaptation or not. When you have two doors, only if it hits properly, you will get the sound. If they don't hit properly, you will not get the sound if it's a floppy valve. So coaptation is also very important, whether they hit adequately or not. That's the second point. One is left atrial pressure and the second is coaptation. And at the same time, how much they open. That is also important. If the movement is opening is restricted, then it will be a problem again. So all these things are going to tell you, play together and tell you whether you will get a loud S1 or soft S1 and whether the presence of calcification is there or not. Calcification will completely, kill the first sound at all, because it's like putting a hand on the speaker that is booming. If you keep on the speaker diaphragm that is actually vibrating, you will not get any sound at all. You can test in your speaker itself. Calcification is like putting a hand on the speaker and you will not get any sound. So all these things really matters when it comes to the intensity of the sound. So you'll get a loud S1 in MS and you will get a TS, and there are many other conditions, including whatever condition that increase left atrial pressure, like atrial septal defect, even ventricular septal defect. VSD, blood is anyway moving into the right ventricle, but coming back into the left atrium through the pulmonary circulation. So left atrial pressure will be very high. So the valve will open fast and open to so much distance and close with a very high force. So in VSD also you can get a loud S1. And many times tachycardia, conditions that produce tachycardia can produce loud S1. Conditions that produce hyperdynamic circulation. What are the conditions that produce hyperdynamic circulation? Like fever, sepsis, beriberi, thyrotoxicosis, pregnancy, children, any exercise, any condition that produce hyperdynamic circulation can produce loud S1, which is a very simple thing. No need to think more about that. But where you get soft S1 is a very important thing in MR and TR, because in regurgitant states, your valve will not hit properly at all in the first place, the basic necessity for producing a hard sound. So because the valve is not coaptation, that is because of inadequate coaptation of the valve, you will result in soft S1 only. And more often the second important cause is CCF and the third important cause is aortic regurgitation. These are the three conditions where you typically encounter something called a soft S1. So in that, the most important will be the CCF and MR and the TR. What is the most important point is they will be asking you about MS in exam. Is the loudness proportional to the severity? First point that you have to notice, loudness is not proportional to the severity of mitral stenosis. That's very, very important. Very common question in exam. At the same time, second important question that you need to note in as far as MS is concerned is that MS is there, but can you get a soft S1? So of course, yes, possible. So they will ask you where you will get soft S1 in the setting of mitral stenosis. One is if the patient is having an associated mitral regurgitation, very common condition. Second is in a completely calcified valve. This is very, very common. Third is very rare if there is an associated CCF. Please tell this point last through the last. You have to tell this last. Because if there is one thing that cannot happen in MS, that is left ventricular failure. Will never happen in MS. Because unless and until there is a significant coronary artery disease or there is some other problem that is affecting the left ventricle, MS alone will never cause left ventricular failure. Very, very important point. It's like I used to tell a proverb, isn't it? I'm not into any religion, but there is a famous saying called Jesus never fails. Like that in MS, left ventricle never fails because it's not receiving blood at all. Everything is accumulating in the atrium because stenosis orifice is not pushing the blood into the left ventricle. So left ventricle is actually thin. It's waiting for blood to come. How can it get failed? So there is no failure in mitral stenosis, left ventricular failure. It's only the right ventricle that often fails in MS. It's not the left ventricle that fails. Left ventricular failure in MS is literally impossible unless until you have other associated conditions like severe MR or it's a dominant MR, or if it's severe AR is there, or if it's a coronary artery disease there, then in that condition you can get left ventricular failure. But remember, again, this is very important exam. In a practical exam, when you go, you tell a pure MS or a dominant MS, and if you tell the apex is dilated, you are doomed. That's the most important reason to fail in exam, which means it's very clear that you don't know the basic hemodynamics in the first place. How can you get a dilated left ventricle in MS if it's not receiving any blood at all in the first place? So that's absolutely bizarre. So nobody can save you. And even if I am there, I will fail you mercilessly because that's so bad. Like telling a dilated apex, big ventricle in a mitral stenosis. Even if you are bluffing, you should be sensible. At least understand the hemodynamics and bluff. So this is something that is important as far as the S1 is concerned. As far as the S2 is concerned, the split and the intensity both are important. As far as the intensity is concerned, you have A2, P2, both are there. So as far as S2 is concerned, you have A2 and you have P2. Both will happen with some gap will be there between second heart sound, aortic sound and the pulmonary sound. The reason is because of the something called hangout interval. You're going to find out what do you mean by hangout interval. Hangout interval is different for both the valves, aortic and the pulmonary valve. So it's not fixed. It's going to be different for different valves. So because the difference in the hangout interval only, hangout interval different. That's why. Because the difference in the hangout interval only, you get different times of beats. And that's the hangout interval is based on the momentum of blood flow. Momentum of blood flow across the valve and resistance. So you can imagine that systemic resistance is very high. So that's why the aortic valve closes fast and the blood will not move for a longer time. And pulmonary vasculature has less resistance compared to systemic circulation. So blood can move for a longer time. So that's why the valve closes late. So that's why there is a normal A to P2 difference. So as far as the intensity is concerned, you know very well where will you get a soft A2. Soft A2 characteristic example is AS and AR. In both the situations, you might get a soft A2 because you might get a calcified valve. That's why in AS and AR. And as far as P2 is concerned, you will get a loud P2 that is more important, especially in the setting of a pulmonary hypertension. That's what you're going to get. That's called a loud P2. Typically happens in the setting of a pulmonary hypertension. Then you can get reduced intensity of P2 or soft P2 or reduced intensity of P2. Where you get reduced intensity of P2 typically happens in the setting of a valvular pulmonic stenosis, valvular PS. So this is a very important point. I'll tell you what is another important point with regards to valvular PS in some time. Then you can get in pulmonary regurgitation. So in that setting, it should be primary. If it's a secondary pulmonary regurgitation due to pulmonary hypertension, then you may not get a soft P2. You might not get a soft P2. If it's due to primary pulmonary regurgitation that happens in certain congenital conditions, then in that setting you can get a soft P2. Apart from that, loud P2 means usually it is a pulmonary hypertension. Very rarely, if there is something called a supravalvular RVOT obstruction, there's a right ventricular outflow tract obstruction, you can get a loud P2 as well. Whenever you talk about a reduced intensity of A2, it's a valvular AS and valvular AR. And where will you get a loud A2? What are the conditions that produce increased intensity of A2? Loud A2 is typically seen in the setting of hypertension, can be seen in the setting of coarctation of aorta, can be seen in the setting of transposition of great vessels, can be seen in the setting of supravalvular AS. Supravalvular AS. So here I can write valvular AS. So supravalvular AS can have a loud A2. And if there is an ascending aorta, ascending aortic aneurysm, these are the examples that produces a loud A2. So as far as the intensity is concerned. So next we need to know about the split. Common conditions. As far as split is concerned, so let us take A2 and P2. Let us see what will happen in inspiration and expiration. Normally, remember, during inspiration, what happens normally? During inspiration, your pulmonary blood flow will increase. Because why pulmonary blood flow increase? Because I told you right mnemonic, isn't it? During inspiration, your right sided flow will increase. So definitely the pulmonary blood flow will increase. So the pulmonary valve will close later. So during inspiration, you are going to hear the split normally. But during expiration, you will not hear the split, because during expiration, the pulmonary blood flow decreases and the P2 becomes closer. For example, A2 and P2 is there. During inspiration, A2 may be the same in the same location. A2 may not increase, but P2 will become farther. That is because of increased pulmonary blood flow. That is because right-sided flow increases during inspiration. So this is what happens. In expiration, it once again comes back to the usual place. Why? Because the pulmonary blood flow will decrease during inspiration and during expiration, so that your A2 P2 will come closer and you will not be able to hear the split during expiration. So that is normal. So this is inspiration, this is expiration. This is a normal entity. Suppose if you are hearing split during both inspiration and expiration, this is what we refer to as a wide split. If you don't hear inspiration both during inspiration as well as expiration, that is what we refer to as a narrow split clinically. And if you hear a split during expiration but not during inspiration, this is called a paradoxical split or a reverse split. Paradoxical split or a reverse split. Yeah, the reason is because in AS, the reason is calcification. That's why I told you specifically. Even in MS, if the valve is calcified, you will get a soft S1 only. You will not get a loud S1. So it all depends on the context what you're seeing. In MS, usually calcification does not happen early. It's only thickening of the valves that will happen. That's the reason for developing loud S1, in fact, even though we know a lot of stuff. But in AS, it's calcification. So you will get a soft S1 only, not get a loud S1. So as far as the split is concerned, this is how you categorize wide split versus narrow split versus reversed split. So what are the conditions which produces wide split or increased splitting? So we can write here and see. So A2, P2 is there. So to produce wide splitting, either A2 must be early or P2 must be late. P2 must be late. So either A2 must happen much early or P2 must happen much later. So then only you can produce this kind of a wide splitting. So one condition where P2 can happen early is in the setting of a right bundle branch block. In right bundle branch block, we know that first left ventricle only depolarizes, then only the right ventricle will depolarize. So it will take a long time for the right ventricle to depolarize and they will contract for a longer period of time. So RVP is going to produce a late P2. Because of that, you will be resulting in a wide split. And at the same time, if you have a RVOT obstruction, like for example, if you have a pulmonary stenosis, in that setting, you will get a late P2 only. I mean, for all, will be a soft P2, but there will be a late P2 mostly. So RVOT obstruction, anything that produces RVOT obstruction, like pulmonary hypertension, because of the right ventricular hypertrophy, they might be, like contracting for a longer period of time. So you might get a late P2 in this setting. Apart from that, one condition that produces early A2 is MR and VST. MR and VSD also you can get a wide split. That is because you are getting a like early A2. Why in MR? Because in MR there are two outlets. If you take the left ventricle, the blood comes from the left atrium, and the blood is supposed to go into the aorta only. But in MR, what happens is the blood goes into the left ventricle as well as the blood goes into the left atrium, which means there are two outlets, which means the amount of blood that is going across the aorta is actually less. So A2 will happen much early. So that is the reason why in MR you get this kind of, wide split. Similarly, in VSD, the same thing happens, but VSD, the idea is different. In VSD, the blood goes into aorta as well as towards the right ventricle. So again, the amount of blood that goes into the aorta is less. So the amount of blood that goes towards the pulmonary circulation is there. So that is why even in VSD you get earlier too. So these are the conditions that produces wide split basically. And there is something called a narrow split. So when you look at a narrow split, what are the conditions that produce a narrow split? Narrow split must be due to early P2, very early P2, or a late A2. So same situation. So narrow split means you should have either a late A2 or a early P2. So if this is the case, you're going to get a narrow split. No, left bundle branch block will produce a paradoxical split. So narrow split. So what are the conditions that produce either early A2 or a late P2? Late A2 or a early P2. So it's very simple. If you have a LVOT obstruction, LV outflow tract obstruction like HOCM or aortic stenosis, in that setting you will get a late A2. Because of that, because left ventricular hypertrophy will be there, a long time they will be contracting, so that you might get a very late A2. Or an early P2 can happen in the setting of a severe pulmonary hypertension. Remember, it depends on what kind of pulmonary hypertension. In early stage of pulmonary hypertension, you will get a wide split also. In very severe late stage of pulmonary hypertension, you might encounter a narrow split. That is because of the very high pulmonary hypertension, the right ventricle is not trying to open, but the patient has gone for right ventricular failure. That's why they're having a narrow split. So you can write right ventricular failure here also. They'll produce a narrow kind of a split only. So here I can write AS and HOCM or even systemic hypertension. That can also produce a LVOT outlet obstruction like thing that is due to increased afterload caused by systemic hypertension. All these things will produce narrow split of the A2P2 only. As far as the reverse or paradoxical splitting is concerned, so two conditions that are important for exams is left bundle branch block. Here paradoxically the right ventricle will finish contraction faster, and the left ventricle will contract very slowly over a period of time, which means it will be something like this, P2 and A2. Because the left ventricle will contract slowly for a longer period of time and it will end after the right ventricular contraction. That's why your A2 comes late. This is paradoxical split, or very rarely it can happen in an extremely severe aortic stenosis. Remember, having a paradoxical split in a patient with aortic stenosis is an ominous sign. It indicates patient will die fast. It's a very, very severe and a critical stenosis. That's what it means. Because here what's happening is the left ventricle is so hypertrophied and the stenosis is so severe that is trying to contract for a long period of time, so that it's overshooting the P2 itself. So that's a very severe aortic stenosis most of the time. So that's very important point at the same time. And more importantly, you can get this in patients with LV dysfunction as well. You can get an aortic regurgitation sometimes. That is because the blood comes back into the aorta and comes back into the left ventricle from aorta during aortic regurgitation, and the ventricle has to somehow push this blood for a longer time back into the aorta. So in AR, especially in severe aortic regurgitation, you might get this kind of stuff. And RV pacing. Why RV pacing? Because right ventricular pacing is going to mimic a left bundle branch block. We know that. So RV pacing can also have this kind of picture. And not only severe AS, in severe HOCM also you might get paradoxical splitting. So fine. So these are some of the conditions that are important for exams. And more importantly, finally, we have something called a fixed splitting. So it can be wide or narrow, but doesn't matter. So what do you mean by fixed splitting? A2, P2 gap is less than 20 milliseconds. That's what happens. Plus, there will be no change with Valsalva. That's the definition. And Valsalva is something that produces a dramatic change during the strain phase and release phase. We know that. So whenever you have a fixed splitting, So you have to think about ASD, number one, and then it can happen in right heart failure. Any condition that produces right ventricular failure can be considered as a fixed splitting. Many students ask how in right ventricular failure you will get a fixed splitting, because right ventricle has to change its contraction according to the load it gets. For example, why this kind of changes happen? Suppose if the right ventricular flow is increased, the pulmonary flow is increased, so the P2 closes late. We know that. But suppose if the why the pulmonary flow increases? Because right ventricle produces more contraction. Suppose the right ventricle is failing and right ventricle is not producing any changes in its contraction with this kind of increased or decreased flow, which means it's a failed and a tired ventricle. Even with increased flow, it's not able to increase the contraction so that the pulmonary blood flow remains same. So in that setting also you might get a kind of a fixed kind of a splitting. So this is a very important point. So whenever they tell about fixed splitting, it's not only about ASD, the right heart failure, right ventricular failure is also a very important cause of a fixed splitting. Remember, as far as pulmonary hypertension is concerned, so early pulmonary hypertension will produce wide split usually, but late and severe kind of pulmonary hypertension usually results in narrow splitting only. These are the usual confusing areas. Apart from that, everything else must be easier. And left bundle branch block produces paradoxical splitting only. Don't confuse with that. And if at all you see a paradoxical splitting in a severe AS or a severe HOCM, then in that setting you might result in a you can tell that this patient is having a severe disease, severe problem. So paradoxical splitting in AS is an ominous sign. The patient might die very, very fast. So we have discussed on the heart sounds. And remember, S3 is very simple. S3 will be seen in conditions where you're going to have volume overload, like MR, VSD, congestive cardiac failure. So any condition that produces volume overload generally tend to have a third heart sound. And S3 can be physiological within 35 years of age because of hyperdynamic circulation. And similarly, S4 can be seen in any condition that produces increased stiffness of the heart. Like for example, ischemic heart disease. Ischemic heart disease is one thing that can produce both S3 as well as S4, because by producing failure and volume overload, it can produce S3. By producing more stiffness of the heart, ischemic heart disease can produce S4 also. By far, the most common reason for S4 is systemic hypertension, because it produces pressure overload and left ventricular hypertrophy. That pressure hypertrophy will be there. And AS can cause S4. HOCM can cause S4. Then what else? Elderly patients itself can have S4 physiologically. Age more than 60, S4 is considered to be a very common finding. So because of the stiffness of the heart, because of heart will go for little bit of, you can think like a fibrosis, old heart, stiff heart. So S4 can be seen in elderly itself. So S3 volume overload, S4 is because of the stiffness. And remember, more importantly, S3 is a early diastolic sound, S4 is a late diastolic sound, and both S3 and S4 are low pitched sounds. We know that. And I think S3 and S4 are not very important. And S4 will not happen in atrial fibrillation. A to OS gap is inversely proportional to MS severity. If you really want to know that, that's very simple basically. That is because the right ventricular, if you know the table properly. So this is the only image I used to give for almost all the valvular heart disease. It's quite simple. So if you take the ventricular systole, this is a ventricular systole, this is the diastole, this is the diastole, and this is the systole, and this is the atrial diastole. So you know very well that you're going to get S2 here and S1 here during the isovolumetric contraction. And S2 closest means simultaneously, immediately after this, S2 happens means your mitral valve will open at this point. Mitral will open immediately after S2, your mitral valve is going to open. So this opening of the mitral valve is the one that is going to produce the opening snap. We know that. So if I rub that and write, so you are going to get opening snap somewhere here. Opening and somewhere here. So why you get an opening snap? Again, that is because of opening of the valve. So why opening of the valve produces opening snap? Two reasons: because the valve is thickened, number one, produces sound. And second thing, that is because of more atrial blood that is coming during the rapid passive filling phase. So more the left atrial pressure, more is going to be the pressure that is going to get transmitted. So more is going faster, the valve is going to open. So you are going to get a opening snap faster. So more left atrial pressure means it is proportional to the severity of stenosis. Severity of stenosis. Suppose if the stenosis is more severe, left atrial pressure will be very high. If the left atrial pressure is very high, the opening snap is going to happen very fast, which means they'll quickly open because the left atrium is having so much pressure that is pushing the valve to open very fast. So the opening snap will be very fast. So the S2 OS gap is very narrow. It indicates high severity. If the S2 OS gap is little wide, then it indicates a low severity. In the sense, like you can, I think you can get it. So why it's happening? So that's why S2 OS gap is inversely proportional to the severity in this particular setting. I mean, I think the problem is like cardiology itself is a very huge thing. And if you want to keep discussing, you can keep discussing like 10, 15 days also. That's completely different. So I don't want to do that. So I think we have come to the end of cardiology as much as possible. Whatever is important, I've told you. Let us see. If you want some topic, I'll discuss for another half an hour in the afternoon. But if you don't want anything, so we can move to the neurology after the lunch break. And I think it's time for lunch. 2:45. I think you can come back by maybe 3:45. That must be ideal scenario. Thank you. Bye-bye. If you want cardiomyopathy, I can discuss. That's a very small topic. Maybe half an hour I will discuss in the afternoon. Thank you very much. 3:45, you can come back so that we can start the next session. Bye-bye.